Okay. So therefore, always, if you see any data, which I'm going to give it to you for practice and also for looking at it. So we would like to put to think first is the validity and accuracy. Otherwise, I have already told you. So sometimes we can write the wrong guidelines, wrong policies, wrong understanding of our conclusion if it is not correct. So therefore, these are some of the things that happen in the public health policies in the past. There are hundreds that so many things that we have not correctly understand it, and then we make a recommendation. For example, the 2014 Ebola outbreak also, because you understand about the R0. R0 is a basic reproductive rate, okay? Like, for example, secondary cases that arise from the primary case in the susceptible population. If the population is totally susceptible, no immunity, one case come, and then how much disease can spread. That is R0 for COVID. You know that in the beginning, 2, 3, R0 is equal to 3 to 4. Some variant, okay, even 5. Measles is about 15. Measles are not highest among all. Okay, if you look, so that's why we have to understand about sometime the natural history of the disease, how the disease spread. So if you wrong information about that one, because we don't know about Ebola so much, okay, because of the many types, also misclassifications of disease. Sometimes Zika, we thought that it's a vector-borne, but it's just also transmitted sexually. Transmission. So the transmission dynamic is different. So therefore, your preventive measures is not correct. And then, of course, about the COVID, about the dietary guideline, vitamins, these are the hundreds of things. So that is even in veterinary medicine, even in our poultry during the H5N1, okay, why Thailand is not advocating vaccination, okay, of the poultry, why other countries around also, there are certain things that we have to consider about the local information, local epidemiological informations. What is the risk? What is the benefit? What is the likelihood? So you have to do the risk assessment also to see whether it is going to be best intervention at that situation or not, because some intervention is in one place is good, may not be as good as the other place also. So it has to be local aspects. So I'm giving you some of this, okay? Just many of you might have seen this already. I'm going to go very quick. I'm just saying that when I went to the study epidemiology in 1984, this paper just came out and it became the discussions a lot, okay, about the coffee drinking and pancreatic cancer, okay? And then the Professor Brian McMahon was the one that who's supervising me also, was a major author of this paper. And as you know that the coffee drinking is very common, and he would like to look at the exposure outcome. Okay, I did not bring with example a lot, so this is easy to understand. Coffee, pancreatic cancer, and then what happened was he would like to establish that coffee drinking may cause pancreatic cancer, which is at different level, association and causation. Always think, is it association? What association means? Statistical association, and causation is totally different things. Don't mix together that you see statistical significance and then it means that this is the cause. Nothing like that. You know already because you have studied. So we have to say anything can be associated, okay? But it may not be causal, right? So therefore, he did this study and he gets the odds ratio of, this is a case control study. Go back, okay, what happened to this study? in the selection process, okay, methodology, why this is a problem, okay? And the odds ratio is 2.7. So it means that if, so he said that if you drink 3 or more cups of coffee by this paper, the risk of getting pancreatic cancer is almost 3 times. So who would drink coffee? How many drink coffee? See, a lot. So therefore, I'm just saying that you can imagine, I just show you the earlier one, that how much coffee is being sold in 2020 and 2021. One bag is 60 kilograms, is almost 170 million bags of coffee is being sold. Today is more than 250, okay, million 60 kilogram bags is being sold because coffee is everywhere, okay, maybe even more than the information there. So therefore, if you look at the confidence interval here, you already know the interpretation. If you look at the confidence interval, it says very clearly that there is a significant association between drinking 3 cups of coffee, 3 or more cups of coffee per day, okay? There is a strong association, okay? Because the confidence interval is not include the null value, 1, okay? So therefore, you don't need to do even chi-square test to tell that this is significant. And if confidence interval also tells you that if you look at the width of the confidence interval, what did you see? Is it wide or narrow? Narrow, right? It's narrow. So if it is narrow, it means that the study is quite precise. It means that it's not 1.6 to 15.9. Okay, so we do not know. So when you look at the confidence interval, you will see that whether it is precise or not. Precise means that they have enough cases, enough control. It's not few cases and few controls. It will be very wide, right? Because the standard error will be very big. And then when you calculate the confidence interval, so confidence interval tell us where likely that there is a population parameter likely to be within these 2 limits, lower limit and upper limit. So it tells you so many things. It tells you that it's also 6 far from the null value up to, okay, about if you drink, you're likely to have more from 60% to something more, okay, when compared. So it tells you more than the p-value. P-value doesn't tell you that much. Just tell you p equal to more than, less than, exact. That's what we're going to see. So therefore, this is example that we will take you back again. So therefore, this is association. Okay, the first step when you see statistical association. So associations tells you that there is a dependence statistically between 2 events or more. It means that exposure, disease, dependence, okay, association. And doesn't mean anything more than that. So it's not causal. But there are 2 questions that is going to come up for you to think. 2 questions. When you see the association, okay, usually we'll practice. When you will see the association, things come up automatically to your mind. Okay, is there valid statistical association? From the confidence interval, we say yes, right? We say yes. Is a statistically significant? Can this valid statistical association be judged as cause and effect? Not yet. Not yet, right? Okay. Always, always, when you discuss with your those young vet, and therefore these are some, okay? So when I say valid statistical association, I did not mean statistic alone. This association, when the association occur, of course, you do statistical tests, but behind that, is this association that you see, statistical significant association, which you say, is it also likely to be due to bias or not? Because the information you put in the table are not very well perform, okay, you collect it not very well, there are so many bias likely to occur or not. That's why that is an association, okay? And also it's likely to be so many things. And if you could answer this part, which this morning before we have lunch, we should be able to do something about this, okay, this particular part. And then maybe later on, this particular part is another things that we need not, but you have to prove it, okay? Okay, so today we are likely to do all the above part, but this is, you know already that there are some characteristic, okay? This is Bradford Hill's criteria, and they are modified. You have to look at that once you rule out the question number one, which we're going to discuss a lot. Question number one, is there systematic error? Is it internally valid? Can you do external validity, okay, generalizability, which somebody would like to conclude, okay, you do the one study only in one province, and then you try to tell that it's for whole Thailand, okay, or whole in Myanmar, or in one small township, and then you say the whole state is like that, okay? So whether first internal validity, external validity, okay, and selection information and confounding, all this must be answered. And then you have a strong statistical association. And then after that, you see that the odds ratio is quite strong. There is a biological plausibility. Is there a biological plausibility? Okay, whether your exposure and your outcome. For example, drinking coffee and you have a lot of children. Does it make biological plausibility or not? It should be less, no? Maybe you drink and then maybe more because you do not sleep. You are awake whole night, so maybe children more. So therefore, is there a consistency? Is it only one study? Your study only, and nobody say yes. Somebody said something like that, but only yours. Okay, is there a consistency? At least if it is performed in Myanmar, is it also seen in the Philippines or in some other place? Or you say this is only in Myanmar? We are happy already. Okay, whether you see smoking, for example, and heart disease, whether it is done in England, UK, in USA, in any country, likely to be true. Okay, because there are some consistency. So all this temporal sequence is very important. You already know whether your study design, is your study design exposure come first and outcome come later, or it is like, for example, you cannot believe if the study is cross-sectional, you see, because you don't know. For example, if I would like to say, okay, just think with me, you already know everything. Study design. You see, the study design have experimental and observational, right? So experimental is the standard of study design where we have randomized. Okay, so we can control. What is experimental study design? Experimental study design is you can control the exposure of interest. Whatever your exposure under your control. What it means, let's say if I want to know whether the vaccine is efficacious or not, right? I would like to test. So what is your exposure? Let's say disease X and vaccine A. So exposure is vaccine, outcome is disease. Okay, let's say if I have a new vaccine for malaria. Okay, so I have vaccine and malaria. So what happened is that I would like to design that experimental design. One group receive vaccine, one group receive no vaccine, placebo is under my control, right? So I will give 500 people vaccine. I can use randomization. No bias in treatment allocation of the vaccine. And then I look whether they have more malaria in both groups or not, if they are exposed to malaria in Africa. So, but in observational study, usually what do we do? Observational study, What is observational study different from experimental design? We cannot control the exposure. Exposure of interest is natural. It's not, cannot be controlled. For example, I will show you taking oral contraceptive and myocardial infarction among women. Okay, you cannot force somebody to take oral contraceptive, and I cannot control. I will always, okay, if you take, it should be natural to you. I follow whether. So that's why I have to conduct cohort, case control, case cohort, nested case control, whatever it is. You see, I have a lot of design for observational studies. But experimental study, you can do for drugs, for vaccine, for certain interventions. That it is ethical. Because usually if you are going to do on smoking, on oral contraceptive, on certain kind of diet or exposure, for example, exposure to asbestos, okay, has to be natural because they are working in the shipbuilding. So asbestos will be exposed, but you cannot find somebody that you 1,000 of you and 1,000 of you stay somewhere and compare, cannot. So that is unethical. So therefore, I'm just saying full sequence. Cohort, start with the exposure first and then wait for and then you have outcome later on. But case control, you start with the outcome and you ask for the exposure. So you have to think, okay, it is okay, but there's some limitation. Cross-sectional, you don't know anything about temporal sequence. Which one comes first? For example, I'd like to study A and hepatoma. Okay, I think that if you have vitamin A a lot in your body, okay, you will not have liver cancer or hepatoma. It depends on the study design. You say same research question, but if you design differently, result, the validity will be different. So how did they design? One study design like this, they go to the hospital, they select the liver cancer patients. Okay, let's say 50 liver cancer patients. And then at the same time, when they examine in the liver patient, liver cancer patient, they take the blood and then measure for vitamin A. Okay. So go to the liver cancer patient, take the vitamin A level, and then in the same hospital, take another patient who are not liver disease patient, and then take the blood, and then look at the vitamin A level. And then the result comes that liver cancer patient have very low vitamin A level. So the conclusion is vitamin A. If you have high vitamin A in another group and compare, it protects you or prevent you from having liver cancer. This is the conclusion. Would you agree? You see, you have to look at the design, whether whether it can be causal or not, cause and effect or not. Is there evidence of dose response? The higher the dose, all these kind of aspects that you may consider when you're going to talk about cause and effect. So association, always what you see in the data, in the analysis, it is the statistical association. Don't go very far to say, this one is this one. Okay? Any question so far? So good, because you already know all this. I'm just repeating what you already know. Okay? So come back again. Come back again to this, and then we're going to start. First, about chance. Okay? We're going to learn 3 terms. Here, we're going to learn random error and systematic error now. So when we say random error, what it means, systematic error, what it means, and if you can rule out that odds ratio 2.7, odds ratio 2.7 is due to chance? Not likely, because you look at the confidence interval already, it's not due to chance. Okay. So all the statistical testing that you do, okay, whether it is for qualitative, quantitative, all the statistical tests are doing chance about whether it's due to chance. Is this different due to chance? This 2.7, your question, is it due to chance alone? We will learn about chance. You already know. Chance, is it due to chance? No. Why? Because we did the statistical test and it showed that it's not likely to be due to chance because we put the alpha error at 0.01 or 0.05. So there is a chance, but very, very small. Okay. So likely to be not due to chance, likely not due to chance. We are not saying that it's 100% not due to chance, but not likely to be chance. If p-value is very, very small, then the chance also very, very small that it likely to be due to chance. What is chance? We will see. Okay, you already know. So can you see when I use the word chance? So when you see, when you perform statistical tests, what are you doing? You are asking the question, is the difference between exposed and unexposed? Let's say exposed, unexposed is 1. Okay, reference group. Ratio for unexposed group is 1. Null value is a reference. And then exposed compared to non-exposed is 2.7. Exposed compared to non-exposed is 0.7. Okay. So it means that is 2.7 different from 1 by chance or not by chance? You do statistical test, right? Calculate the confidence interval, or you can calculate the p-value, whatever it is, we will see. And then we already say that it's not likely to be due to chance. Once we say this, then the next question that you have to ask, what I see OR equal to 2.7, is it due to selection, information, confounding or not? That is the whole topic today. And then we will compare with what is interaction. Can you follow that, what you are supposed to listen today? Okay, we can go for lunch. No, not yet. That is the Japanese time. So therefore, I'm just saying that this is the way that I want you to think about when you see a difference when you see the observed difference between exposed and unexposed. Okay. And then we will see some hypothetical information also. Okay. So error, I already defined. It's something that is not correct. When we say error, okay, it means that your experiment, your study is wrong. Something wrong somewhere, someplace. In selection, in information, in analysis, in conducting, okay, looking at the confounding and other things. So your true result and the real result, true result and the real result is not, you don't have no problem if you don't have it. I'm just trying to show it to you when I think if you look at the probability when we are talking about the chance in the future later on, that we will show you that sometimes you have to look deep into the beta error, the power. Okay, what is the probability that you will reject the null hypothesis of alpha error, and then how would it affect the other things? But anyway, I will show it to you. So therefore, error here, when I say error, I means 2 types: systematic and random. Okay. And this is the whole thing that I want you to know always. So when you're going to ask that, is my estimate free, have a systematic error or not? Okay. Is it due to random error or systematic? What kind of error we are talking about here? When we say bias, what do we mean? When we say bias, we mean systematic error. And when we say systematic error, here, when we say selection information confounding is here. This is very important. The systematic error. So systematic error is very important. The most important. You cannot have systematic error. Therefore, we have to take care. So what is this systematic error mean? Error due to factors that related to the design. If you in your study not, you select the wrong control. We will talk about how case easy to do, but the study very, very important. What your even if you when you use questionnaire, you use diagnostic tests. How you diagnose hemorrhagic septicemia? Okay, in animals. Okay, how do you know that it's not hemorrhagic septicemia, but it is anthrax? And how you differentiate? If you diagnose, what is your diagnostic methods? What is your criteria? Are you based on clinical or molecular? Okay, or the DNA, RNA kind of things? Are you using PCR or just clinical diagnosis? All these kind of things will lead into measurement part. You have to ask this question: how you analyze your data? Okay, so today this particular part, systematic error or bias, is going to be the important part of your thinking. That part is easy. That part is no problem because it's a random error. Random error can be taken care of by increasing the sample size. If you have enough sample size, the statistical part is not a problem. Okay, if this part is correct, then this part can be taken care of. But this, even if you have a very large sample size and this part is not correct, then you have a systematic error. And what we say is bias. Okay, can you see? Can you see the things why it is important? And therefore, I would like to summarize like this, okay, for you to see this particular part is that when we say bias, we mean systematic error, and bias also linked to validity. If you have less bias, then we say your study is valid. Okay. So that is no problem at all for you. So therefore, if you have a random error is related to precision of your study. Okay, if you have random error, then it will affect your precision. But if you have a systematic error, it will affect your validity. Okay, and you see, and then I will show you slowly about this picture. If you cannot understand, please raise your hand anytime. Okay, so this is the roadmap of today. So by the end of the session, you should be able to say what is validity, what is precision, what is random error, what is systematic error, what is all kind of this. If you cannot answer this, you will not leave this room. Did you bring your mosquito net? Okay. So that's what I'm just saying. Okay. Just imagine this is a conceptual idea. What we are doing is similarly like this conceptual idea. It means that our main aim is to have accurate, non-biased estimation. Okay, so accurate, valid, non-biased estimation, valid, accurate. So it means that the truth and your estimate must be very near to each other. What is something that true and something that you got from your it should be here. Okay, here is okay. This is the real life, real world. Okay, it means that you may not have in the middle all the time, but it's not very far away from what the truth is. It's still okay. Okay, but it's not precise. It's not precise because every time you repeat, it means that I ask you to shoot 8 times. Okay, if every time you shoot, it means that you design so well, you collect the data so well. If you repeat so many times, it doesn't matter. You will get similar. But sometimes, okay, when you do the study, many people do the study, maybe, but still, it's not far away from the truth. It's still accurate, but it's not precise. But this one we would like to avoid. It's precise, but it's not accurate. I ask you to shoot on the head, but you shoot somewhere else. You shoot on the leg every time, and then you are very happy because every time you shoot, it's near the leg, like this. So you are not shooting here. So this one is not full of systematic error. So therefore, okay, let's come to random error first. Now we're going to talk about random error. Random error is what? So if you look at this, if you are talking about this, how many people sitting here today in this room? 21. Include you or not?
Yes.
Okay, 21. Let's say in the concept of statistics, you have to know what the statistician they think about. Okay, if you don't know what they're talking about, sometimes it's very difficult to understand. So epidemiologists, okay, must know what is the statistical kind of the concept so that we can see what is that when they analyze it, what it means. We don't have to agree on, but we have to know what they are doing. Okay, so what the statistical people are doing is that this is correct because the concept of population and sample is very important. What we are doing is that we cannot study the whole population. It's impossible. All whole patients and whole populations. But we can we always select subset of the population, part of the population to study. Okay? So what happened? What happened is that so if you go back again, if I go back again, for you to consider, if you look at this, all 21 people, if this 21 people is my population, you are my population now. Presume. This is the ultimate population. So I would like to calculate your average age. Okay, when we are talking about population, statistician, they put in the Greek letter. If I would like to know your mean age of my population, they put it in Greek. So in English, if you say in Greek, you are talking Greek to me. It means that I don't know, I don't understand. Something that you don't understand. Nobody know. Gods know. So do you know what is the average age of the Thai people? Whole country? From newborn to 100 years old or whatever it is, average. We cannot, even if we have census, our census is not that accurate. So that is mu. So nobody knows about mu. Okay, this is value nobody knows. But now today we will know. Okay, because let's say this, you are my population. So we have 21 people, including me, excluding me. Okay, otherwise it will be biased. So this 21, looking at your face, what do you think is your mu look like? Is it 40, 38, or 52? Huh? Oh, I want you to tell me what is your mu. Huh? Looking at the people sitting here, how much you, what is the number you like? Huh? 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 35? 35, okay? Are you happy? Okay. We have to have some number here. Let's say 35, but you look young. If I cannot, let's say, if I would like to get your data, I will ask you, I will distribute the paper, right? I have a box. Please write your age. Huh? Accurately. Don't tell me something wrong. Huh? Let's say no information bias. So you write your age. Then I calculate, right? I get 35. Now I say that no, I cannot do all 21. I want to do only 5. I don't have time. I don't have budget. I have limitation. I want only 5 people, information from 5 people. That is my sample. I want this sample. So if, what do? I have all your names already. We call sampling frame. Sampling frame. When I say sampling frame, what I mean? All the list of your names in my box already. That is a listing, 1 to 21. But I say, I will not take, I cannot calculate all that. So I pick up randomly from that 21, random. Random means everyone have a chance, random sampling. When I say random sampling here, everyone have a chance of being selected, right? I do not know who, I just put my hand there and pull 5 out with it. So I got a sample of 5. So what you are, I would like, so I see your age there. So I will try to calculate from 5. I am not writing mu anymore. What I'm writing, X bar is mean from sample. Mu is population. Now, my question is for you to understand. When I calculate this X bar, I say X bar 1 the first time. Would this X bar same as mu? Or is this X bar lower than mu? Or this X bar more than mu or equal to mu? What do you think? Random. I use random. This is the statistical characteristics. You have to know because you will understand random error. And then you will never be afraid of statistics anymore. What do you think? What do you think? Equal. What do you think? I already giving to you now. So I just pick up 5. What do you think? It will be what? Equal? Okay. What do you think? Hypothesis. I'm not testing any hypothesis. I just want to know what is your age look like. But what happened is that why did I take these 5? Okay, I have to tell you first. Because I cannot take 21 in the real world. I cannot do that. I will always use sample. And once I get the sample, what I will do? I am trying to make the inference to my population, mu. Here, I'm not stopping here. I'm trying to infer from here to here. I will say that's what we call inferential statistic. We will see when you do the statistic. So what happened? But here is only one sample. I'm just saying. So what happened is that when these 5, let's say I select 5. Let me pinpoint. So first time I select U1, okay, 2, 3, 4, and 5. What do you think? It can be high. It depends, as you said. So you cannot. No, I'm just saying that it can be here. It can be here. And likely, less likely that because the sample is not 21, it's already 5 to be exactly. There is a chance, yes, but very low, right? Still, but it can be here, likely to be. You cannot predict whether it will be less or it will be more, or sometimes it may be not likely, but small, very small chance, because you need 21 to get 35. If 5, let's say, okay, so therefore, it can be, let's say, it can be, let's say 36.8 first time. Let's say if I put this 5 back, I take again another 5. I calculate X bar 2. Okay? X1, X bar 1, X bar 2, X bar 3, X bar 4. I keep on doing like that. It will be either less or more, less or more. Sometimes maybe one time in 20 times, it may be very near to 35. So that's why it's called random. Why it's called random? There is some different, like it will be different. It will be different. This 36 is different from this 35. Have you done anything wrong? It's not your process. Your process is very good. You select random sampling from the population, but still, it is different from mu, right? And then this difference is called what? We call sampling variability because of the sampling error, or what we call as random error. Also, it is different from here, X bar 1 and this one. Is what? Is by what? Why this different happen? Is by chance. Right or not? Because you use sample. That's why every time you use sample, there will be some different. And different is by chance. Usually we call sampling variability, sampling error. Okay. Even the X bar 1 and X bar 2, second time it may be 34.5. X bar 1 and X bar 2 also different. X bar 1 will not be equal to X bar 2, and X bar 2 also different from mu, and also different if you have 2 groups. Okay. You would like to compare 2 groups, different. That different may be due to something like this also. Can you understand that? What the difference you see may be due to chance. Nothing else, because sample and sample. So therefore, random error is what? Random error is fluctuation. Fluctuation of what? Fluctuation of your value. The observed value fluctuate from the true estimate. Your mu is the true, and your value is fluctuating. Can be more, can be less, can be more, can be less, like this. And why it happened? Because of chance. You use sample. So long as you use sample, you will have random error. Okay? More random error, less random error, we will see in a minute. Can you follow? You want any questions? Yes.
I have a question
Yeah.
about the error sampling. You said that for the first sampling, it can be different from the second one. In the reality, what is the recommendation that what we choose the first place and we use that sample? Is it okay?
That is the real life. You have money of, let's say, you got a funding, okay, 20,000 US dollar. You cannot do more than once, right? You will go, but Before you do, you have to design well, okay? And then we have to make, that's why we calculate the sample size. I'm going to have my next question in a minute. Now I change from this 5. I say, oh, I have more money. I would like to have 10. Every time I would like to select how many? Not 5, but 10. Now my question to you. Whether X bar 1 will be near 35 or not? Will be more nearer than when I take sample of 5 or sample of 10. The difference will be smaller or bigger. Why? Because the variability will be less, right? Because you have 10 people. The estimate will be, and X bar 1 and X bar 2 also will be nearer and nearer. So if you have optimized sample size, your estimate will be near to the parameter also. If I increase to 15, it will be better or not? My random error, this is called random error. The error will be random. If I increase my sample size, the difference between my X bar 1 to X bar 2 and then to the mu will be smaller. Okay or not? So I come back to your question. That's why when you're going to conduct case control study, cohort study, experimental study, why do you calculate the sample size? One of many objectives. One of many objectives is to reduce the random error, to make your confidence interval narrower, to make your estimate more precise. You remember my master plan? You go back to this again. Always in your mind. This one should be in your mind. This one. I am doing everything to reduce this error. And I have a problem with this, and I have a problem with systematic error. Now I am going to attack random error first. I'm going to do, because it's easy. Random error is easy. If I have optimal sample size, I can take care of it. Okay? So therefore, sample statistic, then I can make an inference. If I get the odds ratio here, not X bar, odds ratio, relative risk, incidence rate, prevalence rate, I am trying to infer to this population value. That's why I calculate the confidence interval. Why I calculate the confidence interval? What is the interpretation of my confidence interval? One of the interpretation also, I close my eye, I say my mu will be, I'm 95% confidence that my mu will be between these two limits. I can see my population parameter. See, this arrow is pointing here. If it is not X bar, but it is odds ratio, I calculate the confidence interval. That's why your confidence interval is the inferential. You are trying to make the inference from sample to, don't think, it's a number, it's a number. No. So if you close your eye, I see the confidence interval, odds ratio. Let's say this one is, we call point estimate. The one that you see, I put the hat here. Usually in statistics, they'll put the hat because it's hot. This estimate is very hot, means that it's not stable. That's why they put the hat always. So if you put the hat, I say point estimate. Point estimate means what? When you see OR, when you see somebody show you, oh, that is point estimate. Only one value. One value is from sample. Is it enough? I don't want to know the point estimate. I want to know the population. Always you have to ask, I want to know the population value. Also where? And when you calculate the confidence interval, you can imagine. If it is 1.1 to 16.8, This is the confidence interval. What comes to your mind now? What comes to your mind? My God, where is my population value? Almost no effect. Eh? It may be possible it's near 1.1. It may be 1.2. No effect. Your OR means that exposed and non-exposed is almost the same. It's near 1. And can be as high as this one. And where is my true value? I don't know. When I come to Kasetsat University, I don't know where is this national. What is the name of this one? National what?
Institute Animal Health.
You see, very difficult. I go right, I go left, I go here, all around. I'm from Thailand, not from somewhere from Africa. So I still could not find. Very difficult. I did not use the Google map, you see. I used the very remote satellite from Huawei. So therefore, so you need a kind of the directions to tell. So therefore, always random error. Is the study precise or not in the first thing? Do you have enough sample size? The second thing, then you come, is this due to chance or not? Due to chance, then you look at whether it includes the null value or not. If you use relative risk, the null value is 1. If you use the risk difference, attributable risk, the null value is 0. Okay, whether it includes 0, include 1, you can interpret everything by looking at the, and where is your true population parameter lies. That is the kind of, I want you to think about that. Okay, now the next one, okay, this is significant one, don't worry about it. And then you see, systematic error will not be corrected by increasing the sample size, but the random error, yes. So your precision part is done, okay, by optimizing your sample size. Now, you know this lady? Have you? No? Never? This? Huh? ชื่ออะไรนะ What? She's acting in the Hollywood movie, right? Huh? Not Jelena Jolie. It's a very famous movie. Have you seen this movie? $1 billion. Have you seen this? She's a boxer. Very nice. And then Clint Eastwood, and then this movie is very good fun. But why I'm showing you this? I'm showing this to show you that this is the population parameter. Look like this. If I'm going to take some sample from this. This is the population parameter. Look like this. Very clear. Very nice. Nobody knows. Even if you see, you don't know, you see. Now, what happened if I take from that pixel, I randomly pick 250 pixel? Can you see anything? Almost nothing. Don't know what even. Very blur. Wide confidence interval. I cannot see anything. Where is the my true population parameter is? If I increase my sample size to 1,000, from that pixel, randomly ask the computer to pick up. Okay, there's something. I don't know whether it's a lady or not. When I increase to 2,000, you see, that's why all the polls, most of the polls, CNN poll, that poll, this poll, they never go beyond 2,500. Always 2,000. When you take the 2,000, then it fills the gaps. Then now you can tell it's a lady and who is all those kind of things. So therefore, you can see here that you don't need 1 million pixel. This is 1 million pixel. But you need only because of the things. So you need about 2,000-3,000. Sometimes it may be a little bit more in some condition, but it's enough. And then it's cost effective. You don't need to do the whole population. Even if I ask, I have enough money, give you 50 million, still your estimate will not make any difference from 2000. Okay. So now let me show you this hypothetical data. Now you have been invited to be the expert. Some they are doing for animals. Okay. Veterinary one. Say treatment A to treat some disease in animal disease, treatment A and treatment B. This is their sample size. Okay. Everything. Now I would like you to ask me, then I give you the information. Okay. You can put this into Stata within less than 1 minute. If you use Stata, okay. So you can use, see, you can say tab I. I means that put the number, not from the file. And then they will calculate as though it is from the file. Big. So you're supposed to have 40 sample. You're supposed to have 40 sample, right? 20 receive treatment A. 20 receive treatment B. Now my question is whether the treatment A is better than treatment B. Okay. And what would you go? Let's say for random error chance first. Would like you to study about chance first. So let's say, what do you think? In your just view quickly, which one you think it look like to be better treatment? B, right? So how many percent is the treatment B? What is the successful rate for the treatment B? How many percent? 70%. What is about the treatment A? 35, half, right? 7 out of 20, right? So it's 35%, right? So if I put into Stata, okay, just 1 minute, I put 4 numbers only. I will get the same. I can analyze anything from this 4 number. Similar, you don't need to put raw data. You can have summarized that in Stata also. Now, what else should I do now? I know that. Should I do the chance? My question next is what? Is the difference? Now you see what? Treatment A, 35%. Treatment B, cure rate is 70%. Is there a difference? It is a difference. Difference of how many percent? 35%. Right? Now, this observed difference. You should ask the question now. I told you what question you should ask. Is the difference, is the observed difference is due to chance or not? My next question, now you have treatment A, 35%. Okay, 0.35. Treatment B, 0.7, 70%. Now, this and this is different. So we call, what you call? Observe difference now between A and B. That is an observed difference. What is your next question you have to ask? Is this observed difference due to chance? Is this chance? How can you rule out whether due to chance or not? What should you do? You have studied so many times already, epidemiology and statistics. What is next? How to rule out whether this is due to chance or not due to chance? You do statistical test, right? How you do statistical test? What test? What kind of test you do here? What kind of statistical test you do? Yeah,บอกนะ What kind of statistical test? 2 by 2 table. Yes. Right? Whether it's qualitative, you have a this side is success, right? And this is the treatment A, treatment B, right? We can label it. If we can tell Stata that this is A, this is B, this is success, this one. So if it is the 2 by 2 table like this, qualitative, right? A, B, cure, not cure. Okay, kill, and not kill, success or not success. This is the category data, categorical data. So you use chi-square, right? Very simple. So you perform chi-square. Now I perform chi-square for you. So what happened now? See, 70%, 35%. Okay. Do the Pearson chi-square. What is the chi-square? What is PR? What is that PR here? Probability value. Yeah. What is the p-value? How you interpret? Huh?
Difference.
Huh?
There's a difference.
Okay, let's say if we set the alpha value. What is alpha? What is alpha? Huh? Huh? I supposed to review, not to teach again. Huh? What is alpha? So now you're going to do hypothesis testing now. You're going to hypothesize that. You're going to do the hypothesis testing that treatment A is equal to treatment B or not, right? So let's say you're going to write null hypothesis, right? A equal to B, right? You say that 0.7 is equal to 0.35. Whatever difference is by chance. That is what you do. Do me? Okay. And then you have alternative hypothesis, right? You say A is not. That's all, right? You do by, and then that's why you do chi-square. And when before you do chi-square, you have to set the error, the level of error that you're going to make the mistake. We call alpha error or type 1 error. This is we call type 1. You say 0.05, right? What it means? It means that you're going to, you're out of every 20 times, you will make one mistake. 5% mistake. You set at 5%. You say whether you're going to agree with null hypothesis or you're going to agree with alternate hypothesis, right? You say that I'm going to make right decision 5% of the time. Okay? And then 95% of the time, I will make a right decision. 5% I'll make a mistake. And that's why you will look at this p-value, right? So usually if this alpha value, okay, you set at this one. If this alpha value, okay, is more than p-value, then what happened? What is your p-value now? What is your p-value? Alpha is 0.05. P-value is 0.027. Now your alpha is more than p-value. What happened? You say is you're going to reject or do not reject the null hypothesis. Are you going to go with this or are you going to go with this? Huh? See? Huh? So you will agree with alternative, right? You agree with alternative. Then you say, when you agree with alternative, then you say this is not equal, right? If when you say not, there are many steps. When you say not equal means what? Means the difference is not by chance. Something make it different. Something make it this different that you see, 70% and 35%, not by chance, not by sampling things that I told you just now. It's something. It may be due to B, better than A. Okay, maybe we don't know, but I'm saying that it's not by chance. Something else than rather than chance. If there is a chance, yes, there is some, but it's very low. So I say significant. I say that this difference between A and B, it is statistically significant. Why you say statistically significant? Because your p-value is less than 0.05. You can set alpha equal to 0.01. Okay, 1%, not 5%, whatever you like. So now from here, you see that this observed difference is significantly different. However, when before you do the chi-square, as you already going to tell somebody else, to teach somebody else in the future, then there is something that we have to say before you do the chi-square. You have to check also whether this sample, let's say you have to check also whether the requirement, okay, that the expected value in each cell, okay, must be enough. Okay, if it is less than, so expected. So I asked Stata to calculate expected value. This cell, for example, expected value should be 10, but it's 7. This side also, it's supposed to be 9.5, but it is 6. Okay. Sometimes if it is less than 5 or near 5, then it means that you cannot use the conventional chi-square. You have to do more than that. We call Fisher exact test. This is something that you need to know, because when you use a very small sample size, only 40, and then you see significant, and then you see Pearson, you say you are using the wrong test. Okay, so therefore we have to use the Fisher test. So therefore the Fisher test will tell you, you see, from the Fisher only one-sided, we are using the two-sided because our null hypothesis, our alternative hypothesis is not equal. When we say not equal, means two-sided. It can be less, it can be more. So therefore we have to follow. You have to follow the two-sided. And now what happened to your alpha value? Alpha is now it is smaller, right? So your alpha is smaller than that one. So it's not significant anymore. It's not significant. So now you are trying to conclude that with this sample size, if I do the Fisher exact test, which is more correct, it will not be significant. From significant to not significant if you choose the wrong test, whether it's due to chance or not. Got my point? So these are some of the mistakes that you have to consider. That's why you need to learn statistics a little bit. Okay? If you don't know anything about statistics, then you are very happy already. Significant. I don't know. But now it's something different. So therefore, what are the other reasons? What are the other reasons? Let's say if you go back, what are the other reasons that it becomes significant and not become significant? The reason that we select the wrong test. The other reasons may be, now if we select the right test and it's not significant, it may be something we call power. Have you heard of power? In your earlier training, power. Yes or no?
Yes.
Huh?
Yes.
Yes?
Remember something like this.
No problem. Have you heard or not? That's all. I want you to.
Yes.
Have you heard of type 2 error? Type 1 error, type 2 error, power, something like that. As an epidemiologist, you have to ask this question. Is a must. It's a must that when you see that the association is not significant, you have to ask the question. I see 70%. Are you happy? You see, you should not worry about statistics. You have to worry about clinical significance, public health significance or not. You see, if you see the treatment A, 70% and 35%, you see, much more. I'm very impressed with the treatment B. However, the statistics say it's not significant now. Should I kick out the treatment B out because of statistic borderline there? It said that it's not significant. I feel that I can cure many diseases in the animal up to 70% compared to the conventional A. The treatment A is only 35%. So now I'm going to ask about this now. Is this 40 enough or not? If I don't have 40, I have 80. And if it is still 70%, I can make this when I design. Then when you design, why you have to calculate the sample size? Because if you don't calculate the sample size, you use 40 and then you say it's not significant. And then you say, I don't see anything. Can you follow me a little bit? Important question. When you see not significant and then you see the effect is large. Effect is 70%. And statistics say not significant. Should you worry about it? Otherwise, you will throw away the good intervention. So that's why in Stata now, I see this 40, right? I want to go back to calculate the power, whether they have enough power to detect or not. So now, what is power? Let's go back. I think we have to stay until 8 p.m. I thought that I can go very fast now. So let's say very quickly, it doesn't matter. Because this is the basic things that you need to ask questions step by step. From 2 by 2, you look at the effect, you look at the statistic, whether significant, not significant, if not significant, ask the following question. Is the study have enough power to detect the observed difference? มีอันใหม่อีกไหมอันนี้ ดีไหมอันนี้นี่ของใหม่ของเก่า So the observed difference is we see 0.7 versus 0.35, right? So we have a difference of 0.35. So I say, sometimes you have a very strong effect, but you don't have power to detect that difference. How would we know? I have to answer this question, and you have to answer this question also. So if we go back to เดี๋ยวเราค่อยๆมาใช้ฝั่งนี้ดูนะเรื่องไม่เป็นไรได้ไหมเดี๋ยวได้มันเพราะที่มันเป็นตัวเองมาที่หลังก็ได้ So what happened is that if you look at your concept of statistics from what I have said, this one, what happened is that if you, what is your null hypothesis? You have a null hypothesis here. Null hypothesis is true. You agree that you're going to go with the null hypothesis is true, or null hypothesis is false. Okay, so this, when you accept this, then you say null hypothesis is not true. And then here you reject, or you do not reject null hypothesis. Your decision, reject, do not reject. Somebody call accept, but I say that do not reject. You never accept, because you can change your mind when you increase the sample size. So if you make the 2 by 2 table like this, what is your alpha? Alpha is the probability of rejecting true null hypothesis. If null hypothesis is true and then you reject it, what is the chance that you reject the true null hypothesis? Is 5%. You are doing a wrong or right decision. If you reject the true null hypothesis, A is equal to B, and still you reject it, you are making a right decision or wrong decision.
95%.
But 5% is wrong.
5%.
So here is, so you make alpha or type 1 error tell you the wrong decision that you will make. 95% is later on. So what happened? You reject the true null hypothesis is this alpha. and here is, okay, right? You reject the true null hypothesis. What happened is that if you do not reject the false null hypothesis is false, okay? Null hypothesis is false, and then you do not reject it. Then what happened is that is the type 2 error. It means that null hypothesis is not correct, and then you do not reject it. You accept it. Okay, so it is beta here. Okay, this is we call type 2 error. Type 2 here, type 1 here. I don't know whether you have heard about this before. This is important. That's why I'm asking you. And power is here. 1 minus beta is power. 1 minus alpha is. Okay. So we do not reject the true null hypothesis. Is what you do. You are doing correcting. So this is correcting. This is correcting. Okay. Except this alpha and beta. Can you see that? Can you understand? You can during after the lunch, you can put this and then imagine yourself. So what happened? What is power? Power is probability of rejecting the false null hypothesis. If null hypothesis is false, we will reject it. What is that power? That power, what it means by power. So probability of rejecting false null hypothesis. It means that this is correct. The alternative hypothesis is correct. You got my point? So it means that if whether I have enough power to reject, okay, the false null hypothesis, means that the null hypothesis is not true. It's not equal, but it's different. But I still cannot reject it because I don't have enough power. I don't have money to buy. Okay. I don't have enough sample size to reject it. That is power. Something is false, something is wrong. So therefore, I can calculate it. If you use stata, you can type the command power. You can tell, you see, I can tell stata to say I have 35, I have 0.35. Can you see that? Power to proportion. I have 35. You can use the menu also, but I'm from the beginning stata 1. I use from stata 1 now stata 19 on it. Okay, so I don't want to use the menu. Menu also very easy. You don't have to write any command. You can click. Okay, so it's 0.35, 0.7. I put it there, and then N1 20, N2 20. Okay, then I calculate the power. The power of this study of 40, only 47%. Very low. I need 80% minimum. I need minimum 80% to detect the difference between 35 and 70. You got my point? So therefore, not enough power. Okay, not enough power. So therefore, I can ask Tata to plot the graph to everything. Don't worry about it. All this I will give to you. So I asked Tata to calculate that if I have this difference 35 and 70%, and I want alpha equal to 0.05, and I want power to be 90%. I want very strong. If that is a difference, I want enough sample size to detect the difference. How much sample I would need? You ask the question like that. And then they say, not 20 per group, but I need, with this difference, I need only 41 per group. If I have 41 per group, I will have 90% power. Then definitely I can detect it. And then there will be enough for me. Got my point? Sometimes you have a good intervention, but you don't have enough power. So you always ask the question when you see that there is not significant association, but the observed difference is a lot. Let's say odds ratio equal to 4, odds ratio equal to 3.5 or 5, but not significant association. Then you say, okay, it's by chance, by statistic, but whether we have enough power to detect it, that observe different or not, that should be your question all the time. And then you can use R to do what? Calculate what I calculate also. R can do. But I'm just showing you the data, how it can be done. But whether you do by any software, you must know how to ask the question, how to proceed your step. That is more important. Can you follow? So for random error and for the chance aspect, sample size is very important. Why? Enough sample size gives you more power. Enough sample size gives you a precise system. Always think. Enough sample size also tells you the parameter value. Okay, when it is precise. It tells you also statistical significance. So all sample size tells you everything. It makes the standard error smaller. Can you see that about the sample size? Why it is important? And then you must detect it in your thinking. When you design the study, you have to ask, do I have enough power to detect? Let's say your hypothesis is that one village, I'm going to have intervention. Certain intervention, let's say education to this village, understanding about zoonotic disease and this and that. And then I would like to look at that preventive behavior, KAP. And then another compared to another village that do not have education package. You would like to compare them. And then you say that if in the village that you have intervention would have the effect size of, let's say, lower, better knowledge by 40%. Then you know the difference, and then you ask to calculate the sample size also with the error, with the power. Okay, so that's why this is the real world that you should be able to do it. Then you're thinking when you do all the time, then it's become easy. Is it difficult or not? You think not difficult, right? You can do anything. Yes, go ahead. This proportion is from the data. You see?
Yeah, this time is no data. Try to design.
Yeah.
You know, the study.
Yes.
Calculate the sample size.
So we have two ways. Okay. One, the best possible looking at the literature or previous study. If it's not that, then you do pilot small. You do small pilot or guesstimate also. You estimate also and guess also to say that the different likely to be from here to here. Nobody knows, and in the actual we do not know also sometimes. So, but you have to have a scientific kind of the estimate or guess to see that if I have intervention like this, it should be 20% minimum, and as high as 40%, or 15 to you see. So that is your guess, but you have to have that one. Without this, you will not have it. How? Nobody have done this study before. So you are the best person if you want to do this, to think about it. Okay, try to search from the possible studies and try to interpolate to see that for our study, similar education, KAP, let's say knowledge improvement, cognitive improvement, practice, and then perception improvement likely to be what in this kind of population. So that is your estimate.
Later you try, you know, a lot of numbers. You know, try to make a table of the number.
Yes. You can do that, and then the Stata can do it also, and then other many statistical value can do that. You see, I can do this also. I say P1 and P2. Okay, and then this is the power, and then this is the relative risk. I divide P1 by P2, and then I calculate maybe the relative. So if I have the higher the relative risk, I will have more power. But the difference is important. If my odds relative risk of P difference between P1 and P2 is more, then I will have small sample size. They will calculate everything for you now. When I study in 1984, no computer like that. I have to use by hand. You can imagine. Before I finish my thesis, I would say that it's so difficult. Typing also the old type. If I type the mistake, everything wrong, I have to use the new page. Now everything is with the AI here today. Oh, if I have to do the thesis, I have to do the medical study, my life would be totally different. I suffered a lot during my time. You should be lucky. You are still young. So therefore, I'm just saying that this is I want you to ask the question. Whether you do not have the significant difference between the two groups, you have enough power. How do you know? Then you calculate the power. Okay? You can calculate the power. Then you say that your power is not enough. You see, when I look at the thesis, student thesis, I look at the difference, I put that into the computer, then I ask them, okay, you have to discuss, you have to say limitations of your study, whether our research have limitation or not. It's okay. We can say that the future research, you can suggest for the future research. To say that in the future, you should, this study have some limitation because the cases of rare disease, the animal disease for this is very rare. Okay, for 2 years, you get only 40 cases, and then you have 40 control. You can have more controls, but still, okay, it's a very important kind of thing. But don't stop only there. Okay. Now, go next. So now I say that you can calculate the sample size. So this is about the part about the chance, about the random error. Why it's called random? I told you already that it is unpredictable. You don't know whether it is lower than the true estimate or it is more than, it's unpredictable. That's why it's called random. If it is predictable, then it's not random, like random movement. You don't know somebody is drunk, whether they will go right or left. That's why we call random movement. Okay. Now we go to the systematic error. Yes.
In the way like vice versa, because when we do the surveillance analysis, surveillance data analysis, sometimes we have so many data, and it can be like 10,000 data, and because of the number of, let's say it's like the number of sample that we have is too many, and it makes significant different, or it makes statistically significant. So what happened in there?
So you see, this is what I'm just telling you. This is the kind of the planned research. Okay. So from the surveillance, sometimes you collect a lot of data. In fact, you collect here, collect there, and then you do a lot of statistical testing. When you do a lot of statistical testing, okay, multiple comparison, then you will see that there will be a chance we call Sheffey-Bonferroni kind of the effect, that when you do many statistical tests, by chance alone, some will be significant, which is not important. You got my point? That's why you have to make your mind also that if you're going to make that's why in my command, did you see that the continuity correction? It means that if you do multiple statistical tests, your p-value, your alpha error will have to be put smaller and smaller. Not alpha equal to 0.05 anymore. It should be divided by the number of times that you test, and then you have to set that your alpha to a very low level. So that's what we call continuity correction. But anyway, if possible, you have to have a very clear to see that what kind of association that we would like to see. We call a priori hypothesis. Means that you set up the idea first that in your surveillance data, okay, what kind of thing that you are making a surveillance? What are the factors? You will try to set that one. You are not trying to make comparison, okay? Unless that you have the evidence or let's say idea that this kind of factor, not fishing, we call fishing expedition. You just throw everything to the statistic and ask them to test everything. So that you will find some significant, and that significant may not have any public health, veterinarian health, public health importance at all. But it will be some, let's say I ask the student to test, please test whether wearing the red shirt or white shirt have a significant with malaria or not. You will find some significant, whether you have more malaria or not. Depends on whether red shirt is more than, but in fact, there are so many confounders. Okay, I also asked them for the survey in the community whether the house that have television antenna and no television antenna associated with malaria or not. Yes, that is strong association, but that is indirect. Once we go deep into that, the house that have the television antenna, ultimately, they related to the sleeping time. Because they have television in the remote area, they watch television longer at night. So they sleep late, and then they will be likely to be bitten by mosquito more than the house without television because they will sleep earlier. Because nothing to watch, no program, no things. So therefore, then maybe important that you find, but you have to see that how it connects. But by chance alone, you will see significant association. So therefore, what I'm trying to tell you here is that when you design the surveillance also to see that what are the factors that should be optimized your decision making. Sometimes we connect so much. Hey, they put the file so long, and then we send in the Excel sheet, and that's why in the surveillance information we have to know also that sometimes that it's not bad. I'm not saying it's bad, but sometimes too much is too much, and then it's do not have way to analyze. So therefore, the surveillance system must have a system that we can automatic analysis with the variable. Now in the research now, what we use is the data facts. So from the paper, we just facts. And then you come to the software. Software read automatic, no data entry. They just read the facts and then they will do the data entry. But you have to have a person to check whether the machine read the facts into the data entry system correct or not. We have a QA process. So you know that it can read, but then you also write the SAS program for it that when you read the data, what kind of data cleaning process, what kind of analysis you should perform automatically. Now you can, with the surveillance system today, with the software, with the AI system and all the things available, you can do all these things without using that kind of the manual and the things anymore. At least if you look at the malaria in Thailand, malaria, we call the malaria information system. It is built, this one, okay, by real-time malaria surveillance system. So what happened is that at the village level, each house location, if there is a malaria today in Thailand, okay, if you go to get access also, malaria information system, MIS, you can see the real-time malaria report. They will allow anyone to go and see at certain level, but it can be late. So what happened is that GIS also, once you detect malaria case, then they can send this location to the investigation team we call 137. One on the first day notification, third day investigation, 7th-day intervention. You see? So all this information will be available. So I'm just saying that for with the web, if there is any farm that you have the death of the poultry, okay, the person, the owner, take the picture, send the locations coming to there, and then it will be located immediately that there is a death of the poultry. Okay, I don't know what is the cost. Okay, it may be important, it may not be important, but at least you can have all those surveillance information for early warning system that we can take care. I'm just saying that more digital kind of so I hope that is now this part is more important. Why it will take you to 8 p.m. because this part, okay, the same. They make them afraid. So by 3 o'clock, all of them will be gone. So that I can go early also. So this is the difference, systematic. Now you look at the master chart. Always remember the master chart. Systematic error. Systematic error related to validity. Systematic error related to bias, what we call to bias. Systematic error, we have a very, very important part on selection information and confounding. If we have systematic error in our data, gone, cannot be corrected, except confounding that you can take care in the analysis. Okay, so selection and information you can take care only in the design. So when you design the study, always careful of selection problem. How to select the sample is very, very important. How to obtain the information, how to measure the information. Measurement is very important. Even if you say, I would like to know whether they how many days that they have the sign and symptom. Sometimes it may not be correct also. So see, when you say fever in Thai, whether you have fever or not, maybe they feel not the fever. When we say fever, Thai, when they ask, the perception may be different. And in the veterinary section, how would you know the animal have fever? That will be even more difficult. They cannot talk. That's why they are very happy. We are very happy. Next time I would like to be vet, because when the dogs or the cattle come, I can treat anything. They cannot complain, except the owner. Just so the systematic error is if it deviates from the true value. Okay, this part is just fluctuate. Okay, but because of the systematic kind of the aspects. So this is the true value. If it is due to measurement, due to selection, due to so many conditions that it makes your value here deviates from the true value, then this is bias. Okay, or systematic error. So therefore, the consequence of bias, what will happen is that the bias, if it occurs, your relative risk, when you calculate from the 2x2 table, will show it to you. When you calculate the the relative risk difference, odds ratio, okay, and all kind of the effect measures will be distorted. I use the word distorted. It means that it's not going to be correct. Okay, it will be deviate. It will be wrong. It will be not correspond to the truth. Then we call distorted. Okay, I have to use this big word. Okay, because this is the best word. I feel that we use that. If your odds ratio, relative risk, incidence rate ratio, hazard ratio, okay, whatever it is distorted. Okay, due to your design, okay, your measurement, okay, so that you don't have to remember, or your analysis. Okay, how you report your data, you analyze the data. If this is distorted, then you have bias. So this is systematic error. And then it will lead to reduced validity. Okay, try to link all this together, and then you will see the picture. So therefore, now we will do all these three. Okay, first. But before that, I would like to introduce the word validity. When I say validity, okay, so that validity, okay, this if no bias, then it will be valid. Less systematic error. And then in the observational study, we try to make the bias as small as possible. So there are two terms, okay, that you need to know, okay, before we go to the selection bias. Usually we use these two terms a lot: internal validity and external validity. Okay, internal validity and external validity. Internal validity, I means that from your sample, okay, from your study that you are conducting within your study, okay, population, from the selection of the sample measurement inside, okay, your study design, it should be free of bias. And then external validity means if you have internal validity already, then you can extrapolate, generalize the result beyond your study population. This is within your study population. Let's say if I study in Kanchanaburi province, my research, okay, I have to make sure that I have internal validity, mean design well, measure well, analyze well, and then I can infer to the population that I select within the Kanchanaburi province. And if this is well done, then if I want to going beyond my study population to another population, okay, to the northern part, southern part of Thailand, or even going beyond Thailand, going to Myanmar, or going to Bhutan, or going to somewhere else, then we say external validity. It means that I can generalize the result from the study population that I select to beyond the part. So usually the people study somewhere here, even within this have some problem, and but they're likely to generalize to the other populations, okay, which is not likely to be. So I would like to show you some example. Let's say just for the selection only, I'm not talking about measurement and other things, but for you to see the kind of the part. So here we have three terms. Usually when if you look at the terms here, let's say we have study population, the one that we select as a sample. Then we have another one, we select from another population we call eligible population. And then we have the source population, okay? So, and then that is similar to the target populations. So what happened is that, I'd like to show you some example here that you can see here. Let's say this study is, this is a true example, that the research question is that in the early 1986 or 87, they would like to know what is the prevalence of HIV among IV drug users, okay, in the US. So what happened is that, what is the study population? Study population that they select is that those who are eligible and agree to participate. So that is the ultimate one. But if you look beyond this, how this study population comes from, you see this population. What is the source population? Source population are IV drug users, which come to the hospitals, clinic, and other health facility in the US. So they say that source population is those who come to the hospital in the US who are IV drug users. Okay, that is their source population. But they cannot study all, I told you. This is too big. They cannot study all this. So they go to another level. they call eligible. Although they think about all the hospital in the US, but in the eligible, they say only they random, let's say maybe 3,000, 4,000 hospital, they randomly from that big hospital, or from that only to 9 hospital only, okay? And clinic during the 12 consecutive months. All the IV drug users who come to this hospital, okay, the 9 randomly select hospital, this is their eligible population. If you come to this 9, you are eligible to be included. You got my point? That is we call eligible. So from the source to eligible. And then now come to study pattern. So those who agree, okay, and get HIV testing, that IV drug users, and then you agree. So it means that you have to agree. You have to give a consent. Not everyone will agree. So this is the methodology. So that's why I'm saying that when you get the result from your study result, where you infer, first you have to make sure that this study will be inferring to this first, right? Eligible first, because you have randomly select only 9. So whether this represent that 9 hospital in representation, okay, in the prevalence. And after that, if this can be inferred to source population, is the remaining of the US can be also similar or likely to be generalized, infer to this source population. You see? And then the target population is the bigger one, is everyone in the US. Okay, so this is what we call as the up to the source population here, what we call as here is up to the first state is eligible, and if it is no problem, then we can think about that it is all the IV drug users in all the clinics and hospital in the US. That is a source. So if you interpolate from here to here, if your design everything is nice, then we say it is internally valid from your sample to eligible population to the source population. And then if you can generalize to everyone, not only the IV drug users, not only the hospital and clinic, but everyone, okay, beyond the hospitals in the US, then this is we call externally, okay, can generalize to the external population. Can you see that one? So sometimes the people have some small data here, and then ultimately did not select from the source population, did not randomly select to become the eligible, and then so you have to look at the step whether your study are internally valid. Okay, if it is a small one, then you say in Kanchanaburi nobody is going to argue with you, but usually they always try to make a conclusion beyond the study population to go to the external population, which is not externally valid or generalization. So this particular part is very important that you have to consider. So once you understand about the validity, this is some example. You can look at my slides later on, and then you can look at it. So before I go to the selection bias, okay, I would like to tell you about the direction of the bias. And then I will go a little bit fast because we don't know exactly what is the difference between true value and then our estimate. We do not know, but we can tell the direction. I will show it to you today. So I will tell you that whether our bias is towards the null or not, whether it is away from the null or towards the null. Okay, that is our direction of bias. Or we can say the third one, let's say now, let me write here again, switch over bias. There are 3 types of directions that we will see today. Okay, direction of bias will be towards the null. What is null? What is null? Null depend on your measurement of effect measure, whether you use relative risk or risk difference. Always think about this. If you use odds ratio relative risk, your null will be 1. So always thinking that our bias will be towards the null or away from the null. Away from the null. Okay, towards or away. So what happened is that, look at this one. If the true relative risk is 4, if the true relative, so if you look at the scale of the null value, okay, if I use relative risk, so my null value, relative risk equal to 1 is my null value. Here is null value. And it can be, relative risk can be 0, and it can be infinity. It can go anywhere. So it can be 1, less than 1, more than 1. This is maybe harmful exposure, protective exposure, right? Relative risk equal to 1, more than 1, it means that the exposure is going to be harmful to your health or maybe beneficial to your health. So if the relative risk, if the true relative risk is equal to 4, let's say somewhere here, 4. Okay, relative risk, this is true value. I'll tell you what is the true value, like this, okay, in our estimate. Today we will see from the example. And then your study finds relative risk equal to 2.8. This is from your study. This is the true value. Okay, I told you in the beginning that nobody knows, but in fact we try to estimate it. Okay, where before we control for the confounding, and after we control for the confounding, before crude, adjusted, and other things, we will see that. So if the study value is 2.8, if the true value is 4, what happened is that true value should be here. You should know this value, but if you do not remove bias, then the study value will be here. What happened if you have bias? The bias will be towards the null. And you see that? If the true should be 4, your study is 2.8. So what happened is that if you report 2.8, what will happen? Your bias will be towards the null. That is what I mean by that one. And also, if it is the relative risk less than 1, okay, if it is less than 1 and more than 1, if it is less than 1, let's say true value is 0.61, 0.61 is somewhere here, more than 0.61 is here, 0.61, and then that one is 0.84 is here, 0.84. So this 0.84 is near null value, then the true value. Then we call towards the null. Okay, it's not difficult, right? Now the next one before we go to lunch very soon, bias away from the null. So it means that the true value is 2 and then the study is 5.5, is away from the null. Now it's away from the null. We will see all this together this afternoon also. And then if for the if the relative risk is less than 1 or more than 1, less than 1, then if it is relative risk is 0.13 in the study and true is 0.55, then this is also away from the null. Okay. You can ask the question again. Okay. So this is the direction of bias that you can see here. 2 things. When I'm going to tell you about the misclassification, I will use this example. So misclassification today in the afternoon, you say if you do the non-differential misclassification or differential misclassification, if it is non-differential misclassification, okay, we will see what is differential, non-differential. The bias of non-differential misclassification will be always towards the null value. You will always underestimate. But if it is differential misclassification, the bias will be both. You cannot predict. This is more dangerous. It can be both ways. It can be towards or away. Okay, so I'm just trying to introduce to those who already forgot, away from the null towards the null. Some bias we got switch over. The third one, switch over, which is little bit. It means that it can be on both sides. One on the protective side, another one is on the. It's not on the same side. Just now I give you the same side. Either it is more than one or less than one, right? But it can be one. It can be a true value, maybe less than one. Okay, it should be protective, but your study says it's harmful, or it will be vice versa. It can be that the study says protective, but in fact it's harmful. Okay, so all these kind of things that I want you to see. It's a little bit heavy, but no choice because the topic is heavy. Okay, it's very heavy. You have to carry on your back. Okay, and this part is important. That for you to help the other people to understand. We need. That's why I want you to see the kind of more or less in the real data. Okay, I will cut short about this because the most important topic could be confounding and interactions that I want you to know, because this particular part is also very important. But I think that we will have to spend more time on how to assess interactions and how to interpret it also with the confounding, why it is different, kind of the concept, and why we have to eliminate some kind of bias, and why interaction is not bias. It is a phenomenon. Okay, so don't mix interaction with this error. But interaction is very important, that you have to how to explain the phenomenon, because your intervention also very important when we have interactions. Okay, so we have a lunch at 12, and then we come back at 1 o'clock. Any question? You want to ask something? Yeah, can ask, no problem. No hurry. We can have late lunch, no problem. Any question? No? No question? Okay. Because I feel that you are very tired, I start at 10 o'clock. No break at all. I go 2 hours because of the 1 hour late. I try to make up the time. Okay? So you can have a break during break instead of lunch. Okay, if nothing, okay, take a rest of 1 hour, and then okay, so we come back quickly, because I will try to go quick because we have so many things to cover. We have only 6 hours left, so I have to finish everything. So the first systematic error that we're going to discuss would be selection bias. This is very, very important. And this selection bias, you have to take care in the design, when you design a study. If you're going to do anything, survey or whatever it is, you have to consider whether how to make the validity, internal validity, and less bias is about the selection. So if the selection bias is the resulting from the manner in which the subject are selected. Okay, how you select the subject. Like the example of HIV and IV drug users, you see, that is the way that they're going to maintain the validity of your selection. So it can be so many, okay, it can be when we select the group to compare, sometimes case coming from one place, control coming from another place, okay? You choose the wrong group to be compared without you knowing. I will give you some example. Then sampling frame, you don't have the sampling frame, so you cannot do simple random sampling. If you're going to design your study as simple random sampling, you need to have a sampling frame. That is a list of all the individuals, okay, in that particular kind of the frame. Otherwise, you have to use other type of sampling, systematic sampling and other kind of sampling. And loss of follow-up, one group in the exposed group lost more than the non-exposed group. It can lead into this kind of problem. So therefore, we'll show you some example. Okay. So this is ไปละอันนี้ต้องไปกดตรงกดแล้วนี่นี่ปุ่มลงก็ไปคนเก่งไปซะละคนเก่งเอาแล้วอันนี้ได้ไหมSo therefore, selection bias, if it as you see it already in the selection process, how you select to be this into your study, all the things that may result into the participation. Sometimes you go to ask someone who agree, only those who agree to come to your study, that also may lead into selection also. Because those who do not agree, you don't know their characteristics. So therefore, how are we going to take care of that one? We call volunteer bias. Means that I would like to volunteer to be included in the study. Okay, the characteristics, the risk factor is different from those who disagree. They're likely to be more healthy also. So therefore, coming back to this example that I gave you to you in the morning about this study. This study leads into a lot of argument among all the epidemiologists in the US. Okay, they discuss a lot, and then the coffee company, they are very rich, so they employ all the professors, ask all the professors to do the study, to comment on this study. Okay, and then it becomes the big news. So therefore, since it is a case control study, I would like to go back to the case control study a little bit. Case control study, we select the case, we select the control, we go back to ask about the exposure. So what is the role of the control? Because this is the retrospective, going back into the past. The role of the control is not just the sense when you think of the control like that. But this control, we are trying to represent this control as the prevalence of exposure in the population. Let's say if you do the cohort study, you would like to know what is your comparison group. So therefore, when you select the control must be representative of your population. Let's say if I would like to compare the smoking among the case and control, the control must be the baseline exposure in the general population. It should reflect that. So if you select the wrong control, the comparison would be distorted because the exposure prevalence will be different than the population. And you think that way? When you select the control, why you select the control? You want to ask the exposure among the control. But if you select the wrong control, the control that likely to have the higher prevalence of exposure than the general population, then your odds ratio will be distorted, okay? So therefore, and this is the case, if this is the difference in the exposure, then we compare this to this, okay? So that is a general thinking. And as I already told you, that if it is represent the expected level of exposure in the population, then it's fine. Now, in coming back to this one, from this paper, what happened is that how these papers select the case. They select the case of pancreatic cancer in the hospital. Case is no problem. When you select the case, you do the they do the histopathology, all the kind of the confirmed by biopsy and this and that. You can confirm the case. But the control, they select the patient from the same ward that come to the GI, because the pancreatic cancer belong to the GI ward. So what happened there? Also select the control from the GI ward, which are supervised by the same physician. And then the control are the other GI problem, not the pancreatic cancer, but the peptic ulcer, duodenal ulcer, all the kind of things, okay, related to GI. So now you have to start thinking that, is this control correct or not? You see, because what happened is that, what is your exposure that you're asking? Okay, the outcome is pancreatic cancer. You would like to assess coffee drinking. So what happened is that if you ask the control, if the control having peptic ulcer, duodenal ulcer, if I ask, you are the patient, you have a gastritis, you have, do you drink coffee? You have duodenal ulcer. When you go to see the doctor, you come to the hospital already. Then the doctor will tell you from the beginning, you have duodenal ulcer, don't smoke, don't drink coffee, don't drink Thai food, this one and that one, you see? So Indian food, Thai food, don't drink, I don't eat. So therefore, you already been asked not to be exposed. So what happened? Your answer will say, no. They will say no all the time. And then it doesn't reflect the coffee drinking level in the population. So what happened? You will overestimate or underestimate. You will underestimate, right? Usually you drink coffee. So when you have peptic ulcer, you will say no. But you didn't tell why no. You say, I don't drink. How long you have drink? Oh, a long time. Because of recurrent coming back and forth. So therefore, the prevalence of the exposure among the control is much lower. And if among the case still the same, right? When you compare, what will happen? A big difference. That 2.7 maybe big difference. Instead of that, there should be no difference, it become different. So therefore, this study, something like it. Let's say this is the source population. If we are talking about the whole big population, about the peptic cancer and coffee drinking, so we should think that the coffee drinking here among the cases and control should be similar to the study sample, right? About the exposure. But what happened when you do the selection wrong? The number in the cell will be different now. It does not reflect in the population, the control exposure to coffee. So therefore, this is a big problem in this study. It is the selection of the control. It's likely that the control is not well selected. This study conducted in 1981. Okay. So that time maybe they didn't think much about this one. So therefore, another study done by Gold et al. This study was published in 1981. And then in 1980, there is a controversy for 3 years. All people are just saying that, how can you say that drinking coffee, more than 3 cups, I drink 6 cups. Somebody say, and then I am still healthy, no problem at all. So therefore, this guy did a study again. Okay. So what he did, instead of selecting the hospital control, he go and select the population control. How did he select the population control? He go to select the one who are next to the case. Let's say if you're the case, you stay in Lad Prao, and then I will look at your neighborhood. Who is your neighborhood? And then we select the control from where the case come from. Okay, I select the neighborhood control. Okay, so that it can reflect the population from each case. If one case coming from, let's say, Silom, then you will select the control from there, from the case that the case come from. Okay, so therefore, it's not from the hospital, not hospital control, but population control. Okay, so therefore, now you look at the odds ratio, then he see this way. Okay, then what is the result come from? Instead of 2.7, it is 1.4. You see, by selecting the different control, your conclusion, your result totally different. So as a mentor, when your student or whatever the trainers, trainees are coming to your department, you have because the 70% of epidemiological study are case control. It's cheap, it's quick. Okay, you will not do cohort because by the time you wait, okay, you already retired and then pop up paper not published, follow for 20 years before you have pancreatic cancers. Okay, so I will only one paper. Okay, throughout my career that I'm going to have. That's why I do cohort study for infectious disease, not for chronic disease. Chronic disease, I will do nested case control or case control studies mostly. Okay, so therefore you will see that this is the selection bias. Can you see this issue? Selection bias. Another example quickly, so that I don't have to go into the other detail because we don't have much time. I would like to give you one study. This is the real study by our MSc student. Okay, I think in 1990 something, 94 or what. One student did a study on mosquito net, the use of mosquito net and malaria. Okay, this is the, and then he did a matched case control study, matched case control study. Let's say case control study. Okay, so at that time you have a insecticide treated nets also, and then a normal net, insecticide treated net, and no nets. Okay, one of the factor of many factors that you would like to look whether how much malaria it can protect. So the hypothesis is mosquito net is a protected exposure. Okay, so what he did is once he did that one, so he select the case. So he went to Thai-Cambodian border, Trat province, and he select the malaria case from this provincial hospital in Trat. So the case who are positive for malaria and who come to this hospital. Okay, this is the hospital-based case. And then the control, how did he select the control? He select the control those patients who come to OPD for any disease and no malaria, and then select as control, and he compare this case and control. Now you have to consider there should be no problem, no? You select malaria case is positive 100% by blood smear, microscope positive as a case, and then control, I select the OPD case. What's wrong with that? Okay, but you have to understand about the epidemiology of the disease that you are studying, because you have to look at the transmission, how the disease transmit. Because malaria in Mekong countries, whether Cambodia, Thailand, Laos, Indonesia, Philippines, or Malaysia, it is the forested foothills malaria, where you have a forest and then foothills, border area, and then it depends on the vector. The mosquito that transmit malaria are Anopheles. Anopheles mosquito in our Southeast Asian region, Mekong region, they breed in the forest area, in the slow running stream. Other thing, it's not like in India. In India, you can have, we call urban malaria, where the Anopheles stephensii is different from Anopheles dirus, Anopheles minimus in Southeast Asia. Okay, so the vector dynamic is different. Like in Mindanao in Philippines, you can have Anopheles dirus, okay, in the forested foothills area where the dynamic is different. In Indonesia, maybe in the shrimp ponds and in some of the other foothills area where it can also transmit. Species maybe a little bit different, environment different. So therefore, case is here, case originate from here. And then case go there to Trat. Now, what about the control? Control should come from here, where the case arrives. But what happened when you ask the control here? What is exposure? Mosquito net. If you stay in the city, I ask you, do you sleep in the mosquito net? You are staying in the urban area, in the city in Bangkok. Do you use mosquito net in Manila? You will say, no, but my house have a screen, mosquito screen. Nobody sleep in the mosquito net, right? In the city. So what happened? The control will answer. Control will answer, no, right? And then the case will say, yes, more than control. So what happened to your odds ratio? Your odds ratio is not less than 1. But your odds ratio will be more than 1. Your odds ratio now, okay, relationship between mosquito, odds ratio equal to 3.1. What it means? 3.1. Sleeping in the mosquito net will make you have more malaria, right or not? Then they call the malaria control program, call me that time. Please come. Something wrong with your student thesis because they're coming from malaria division that time. So I look at hey, you select the wrong control. I'm not his her advisor, but he's doing on something else. So I was saying, hey, the selection is not correct. And then when they change the control later on, then it become on the protective side. It become the 0.68. So it can reduce by 42%. 0.68. So it's a 32% reduction. So therefore, I say that if you select the wrong control, everything can be wrong. And then you will be surprised. Something good, you will tell something is not good. Okay, so be careful. So that's why. So when they do the study just now about that, okay, the exposure is almost the same between the cases and control. So you have to be careful when you select the control from the hospital. We call the bias due to the selection of hospital controls. Usually it's nice to select the control from where the case come from. If the case come from Chiang Mai, the control should come from Chiang Mai, not select the case from Chiang Rai and select the control from Chiang Mai or Bangkok, okay? Because that will be a problem of the assessment of the exposures level in the populations. So therefore, the concept, I would like to show you some of the concept that when you conduct the case control study, always think, okay, of the sampling of the control. So there is something we call study base, okay? We have something, if you read the journal, there'll be something we call population-based case control study, okay, more and more, because of the problem with the hospital-based control, because it creates, unless that you are very sure that you don't have a selection bias, unless that you can defend that your control reflect the exposure, the prevalence of exposure in the population is the same, likely to be the same, then you can do that. So the study base is something like this, that in any geographical area, okay, you have the population, you have the individuals, and then the source population here, there's someone who will be exposed and someone who will not be exposed to certain factor. And then what happens is that someone will have disease, someone will do not have disease. Like for example, you will see the control do not have the disease, and then the case exposed also can have the disease, unexposed can also have the disease. Control also can be exposed or not exposed. So if you imagine when you do the case control study, when you select the control, you have to see that if it comes from the same, then it can reflect, okay, the prevalence of the exposure in the population. So the issue that you should do here is cases and control should be representative. Remember, representative of the same base. The control should be coming from the same base, for it should. So therefore, you ask when you select the control, is this my control that I select coming from the same base as the case or not? If it is from the same base, then you are happy that it will reflect the real problem and without selection bias. So that is the things that I want to tell you. And I will skip many. Okay, but there are types of selection bias. These are the names that you will see. These are the names that you will see in the literature. Sampling bias. Okay, so it means that you are selecting only some group and then you are leaving out from the some other groups. Okay, this is the most common problem. Okay, that you do not use the kind of the selection for the national study that it represents the whole nation. Allocation bias. Okay, so it means that whether you're going to give the intervention or not is not by randomization, but just non-randomized trial assigning. Attrition bias. It means that the dropout in the cohort study is higher in one arm than another one, and then healthy worker effect. This is quite common. It's likely that the people who work in the factory that working age, working in the industry, in the company, are likely to be more healthier than the general population. So if you compare the disease among those, let's say, working in the uranium mining, and then the general population, likely to be that mortality comparison, these are young and healthy because they're still working. Okay, you compare to the general population, it's likely to be that general population will have higher mortality than these people. So therefore, healthy worker effect also very important when you select the people for comparison. Okay, so therefore, these are some of the things that I want you to consider about the selection bias. And also there are other names: volunteer bias, non-response bias. People, when you select the people, you go, when they do the survey in Thailand, always wrong. Okay, doing the sampling, they see that whom is the very favorite for, very popular for Prime Minister. So they go to the bus stop area and ask the student to ask, and then the bus stop area in front of some party office there, and then they ask somebody who's standing in front of the office, say, who should be the next Prime Minister? Those kind of response that you have to see that how they never explain how they select the sample. And then you will see that the poll by this company will be always different. Today is something and tomorrow different again, because of the how you select, and then the response also is you have to consider non-response. Somebody answer the question, somebody do not answer the question. Let's say you ask, what is your favorite? What is your favorite party? Then you don't want to talk, then you are not recorded. And then the one that say this party will be recorded. So that becomes response, more response than another who do not respond. So the characteristic is different. And then another one is the Bergson's bias. Bergson bias is very important for selection bias, that when you use the hospital sample for control, okay, you will have a problem, okay, because of multiple disease of same exposure. Smoking can cause not only lung, not from, let's say, bronchitis. You have bronchitis, you have lung cancer, you have pneumonitis, you have prostate, a problem of the prostate cancer, you have let's say bladder cancer. So if you select the control of bladder cancer, okay, by about the exposure of smoking, then those people also smoke. So the comparison is not good. So this is, we call, some exposure can cause many disease. So you have to be aware of that one when you, and then these people go to the hospital, and hospital have some people who do not have only pancreatitis, but they have also liver problem and other problem can coming from the same exposure. So it can lead to Bergson bias. Okay. So selection bias can result in over or underestimation of the true magnitude of the relationship between exposure and outcome. You have to be aware of this one. Okay, it can lead into away from the null or or towards the null. For example, the coffee drinking The true is only 1.4, but the study there is 2.7. So if you don't control for the selection bias, consider about the selection bias, you will what? Estimate away from the null or towards the null? The bias of the selection. Let's say the true is 1.4. Okay, by selecting the right control, it is 1.4, right? When we do the restudy using the general population control. If you don't do the right selection, it will be 2.7, right? So the bias is away from the null or towards the null? Away from the null, you see? So selection bias. So to avoid only in the design, you have to design very nicely. Look at the representative of the target population of the population to be compared, and look that there is a minimum loss of follow-up in the cohort study. Because you will see that in the cohort study, after the first year, people will be lost. They don't want to come anymore, okay, because of so many reasons. And then those who are healthier, they would like to be in the program. Like Framingham study, they have been done for more than 70 years now in Framingham, in Boston, about the smoking, OC, so many studies about the heart disease. Those who are healthier, likely to participate. Okay, those who are not very healthy, they don't want to know them to look about, so they do not participate. So you may have a problem of also selection. Okay, so I go a little bit quickly to just finish selection so that you are aware, okay, of the, when you select the control, please be aware, select the one that's going to be compared. You have to make sure that they are likely to be compared. If I ask you, okay, you are the vet, okay, very famous vet. There are two famous vet sitting here, okay. If some let's say the livestock, maybe let's say pig have a suspecting of having what is that? What is the outbreak now about staph Suis is outbreak or not now? No.
Yes,
In some area. Okay. Let's say you are very good in Chiang Mai, right? Let's say, and then come to see you. You can take care of this. Okay, the kill rate, the pigs that come or the one that bring, you can advise them, and then the success rate, let's say, is 50%. Okay, and then another vet is 47%. Let's say 45%. If you have a problem with this issue, whom would you go to see? 45% or 50%? This is a very bad question, but I'm just asking for fun. Huh? Okay, 50%. You make a very quick conclusion. Did you ask her how many that she treat? How many she treated? 2. 1 dead and 1 alive. You see, so therefore, as an epidemiologist, you have always to don't go to the numerator. Don't go to the numerator. Always, what is your denominator? Denominator, don't compare numerator and numerator. Sometimes you don't know what is beneath that 50%. 50% can be so many things, right? 500,000 divided by 1 million. Can be 1 divided by 2 also, right? So therefore, always consider the new denominator, because we always forget denominator. And then we say, oh, I will go to that doctor. He is a very good neurosurgeon. Okay. But when you look at his record, he operated only 2 patients. 1 patient dead and 1 patient alive. And then after that, he never operated again. And then he put, I'm 50% success rate. Okay. So information bias is about measurement. You measure everything using your instrument. Questionnaire, you have to have a content validity. Okay. Whether you really can measure knowledge, whether you can measure perception, whether you really want to measure what you want to measure. Your instrument can measure it. Are you sure? Okay. So if you have an invalid measurement, invalid diagnostic criteria, invalid the recording system, your surveillance system reporting are coming from just, okay, we call the event based only, okay, not indicator based. Okay. And then you never confirm, okay, just reporting or clinical, no confirmation of diagnosis. So you don't know whether that is suspected case, probable case, possible case or confirmed case. So all these are mixed up. So it can lead into information, and then it will distort your odds ratio relative risk, okay, due to misclassification or measurement. We will learn about this quickly. So therefore, information bias, I already told you, okay, even incomplete data, poorly definition of the disease or exposure. So this will, the most important part is this, what we call as the something that if it is accurate, inaccurately measured, it can lead to misclassification. So that's what I'm trying to tell you, that in the real life, okay, when you look at this 2x2 table, okay, don't be happy, okay, when you say exposed, here exposure, exposed, yes, no, and then the disease, yes, no. So when I say here, when I say 100, for now, okay. So what happened is that when we say 15 here, 100 here, right? Let's say 1,000, 150 here. We have 100 here, 1,000 here. And then we have 850 here, and then 900 here. When things is in this cell A, cell B, cell C, cell D, cell, when we say this, it means that plus, right? Plus. How do we know that this is really plus? How we know that it's not that some part should be here and some should be here, right? We do not know. So if something like this happen, then it's something that we call misclassify. It should be exposed and no disease. You classify as this one and that one, you see? So this if why this happened? This happened because of your instrument, your diagnostic aspect is not very good. So therefore, you may have misclassification. And this is very serious. You misclassify, okay, in some setting. So therefore, information bias can have interviewer bias. Your interviewer can be biased. That's why when you design a study, you have to make sure that your interviewer are trained, okay, understand everything or not. And then you have to have the third party, okay, to go and then see that whether they observe whether they do supposed to do or not. Because you can influence when I interview. I know that you are smoking, okay, then I'm trying to ask you differently from the non-smoker, you see. I know that you should have some chest pain. Do you have a chest pain? No. Are you sure? You don't have it? A little bit. So therefore, this is it may be this one. Recall bias. Because something that happened in case control study, something happened 10 years ago, 8 years ago, 5 years ago. Let me ask you, very quick question. You answer yes, no. If you know, you can tell me. Let's say 48 hours ago, what did you have for lunch? In 48 hours. See? When I ask, when your daughter was born 5 years ago, did you take any medicine in the third trimester of your pregnancy? That is a case control study, whether you're exposed to drug or not. I would like to do the thing. You see, so you can imagine about, so what happened is that this study we call recall bias, because the mother who gave a birth to a deformed or disabled child will likely to remember better than, because the child is having heart disease, having a kind of the deformed. So you as an investigator, you would like to study about the exposure to certain drug, right? Then you go back to ask. Now this child is 3 years, 4 years, 5 years already. I ask you, when you were pregnant? 5 years ago, okay? In the first time, did you take the drug called monoamine oxidase inhibitor? Yes. That is about the antidepressant or not, this one. Then they try to remember, but they are trying to, sometimes they try to blame some exposure that why my child is like that. You see? So therefore, this is recall bias. You have to consider also, don't trust everything. So you have to say how you're going to control of recall bias. There are ways to do it, but you don't have a lot of time. Surveillance bias, you would like to look into something for a certain group than another. So these are the names of the, I will give the slide to you later on. So you can look at it, okay, and then see that already there. All the slides are there already or not yet? So recall, social by instrument bias, interviewer bias, and other things. So there's so many names, but it doesn't matter about the names. Matter that what this kind of bias make the information and how it's going to affect your relative risk and odds ratio. Okay. I'm sorry, a little bit quicker because you're already exposed to this. You have already done your first. This is your second time, right? For FETP. So it's a little bit faster. And this one also important, something called Hawthorne effect. Hawthorne effect is something that when you are going to observe the behavior of something, let's say hand watching, you're going to do the study that, okay, after the education to the student in the school about hand watching, and after that, whether they wash their hand or not, when they go to the restroom, coming back to the toilet, after the before the food, before the lunch, whether they wash hand. If you watch them, if they know that somebody is watching me, you're likely to have that behavior. And then you look again, they're already gone. It's okay. So this is the Hawthorne effect. So what happened is this is done by the company before epidemiology, because the worker in the company, they do not work full 8 hours. So they estimate that they work only 5 and then talk, going here and there for 3 hours. So what happened is that they say that they are going to watch. They just pretend that they are going to have supervisor watching with the CCTV. Once you put the CCTV, then nobody is, everybody is working because of that. They know that they are work. So they are applying Hawthorne effect on them. That is not the study, but I'm just saying that in epidemiology, Hawthorne effect has a lot of impact, okay, on your data, on your measurement, whether you watch them or not. So now we come to misclassification. So misclassification is, as I already told you, that if you misclassify, okay, the exposure to non-exposed, disease to non-disease, and then vice versa, on the disease status, exposure status, what happens? So misclassification, as I already told you, whether your exposure and outcome classification affected or not. So now there are 2 types of misclassification. One, this you must remember, okay? Must remember first, understand later, okay? First is that there are 2 types of misclassification, which is going to be important for you. One is called non-differential, and another one is called differential. What is that? What are they? Which one you think is serious? When they put things in the bracket there, which one, non-differential is more serious or differential is more serious? See, because this word, you see, this is less serious, you see, when you see this one, this is more serious. And then direction of bias also very problematic, okay? So therefore, let's go to the non-differential misclassification, okay? This also, you must remember first. What is non-differential misclassification? It's less serious. I told you, remember first, understand later. Remember, another thing is that the bias always towards the null. Is always underestimate your effect. If you have odds ratio equal to 4, it will tell you 2.5. Okay, the bias towards the null, always less serious, but always towards the null. But it still have a problem. That is the non-differential misclassification. Okay, first. So when it occurs, so when you classify, let's say this is, if I say, if I put this as case, okay, this is case, and then this control. So I have 250 here. I have 175 here. Let's say cases in control. So what happened is that when I ask about the exposure, okay, among case and control, when I classify the exposure among the cases, okay, and then when I ask the status of exposure, okay, among the control, the misclassification is equal. Means that if I wrongly classify this site by 10 cases, I also classify this site, okay, similarly. So by mix up, it's not very serious. Means that it's wrong on both the side. Not only one side wrong, another side is correct. Okay, I will show you the real data. So the example data. So whether you classify the disease among exposed and non-exposed, or you classify exposed among cases or control, disease or non-disease, it is equal. Okay, it is equal between disease and non-disease if you classify the exposure, and it is also equal if you classify exposure among disease and non-disease. Okay, so this is we call non-differential misclassification. So non-differential misclassification, I already told you, the bias always towards the null value, always underestimation. Let's see the example. Okay, quickly, example. When there is no misclassification, the top one, no misclassification. This one, you calculate the odds ratio 50 multiplied by 80 divided by 20 multiplied by 50, okay, or 50 divided by 50 divided by 20 divided by 80. You can do that way. The odds ratio equal to 4. This is no misclassification. Your instrument is perfect. Okay, that is your true value. True value is 4 in the mu, like mu in the population that we study. But if I say 30% of exposure misclassified in each group, so it means that, okay, exposure yes and no. There are two groups, right? Yes, exposed, not exposed. I say that you misclassify 50%. 50% means here 50 here. You misclassify 15. Okay, so you minus 15, and then this 15 will come down here, right? And then in the control also 30%. 30% misclassify become 14, and on the below here it become so this is instead of 50 you have 35, okay, instead of 20 you have 14, and then the misclassified things come down, come to the outer cell because of the total is 130 here. So therefore, if it is misclassified like this, equal classification of exposure among cases and among control, 30% equal. If it is equal like this, when you calculate the odds ratio, what happened? It's not 4, it's 3.3. So it means that if the true value is 4 and then the observed is 3.3, what happened to your bias? Away from the null or towards the null? Okay, this is clear because it's less than the true value and then it's near 1. Whatever the near 1, it's towards the null. Remember like this. So therefore, this is towards the null. Look at the example. Example, here also same. I can tell you that even the cases, if I say that more 10 cases, more here, 10 cases, more here, when compared to the true value, instead of 100 become 110, and among the control also 10 cases. You can have percent, you can have case, you can have sensitivity, specificity, put it there, whatever you want. But if it is equal, so here is 2, here is 1.8. Here also less, underestimate. It depends on the numbers. So therefore, bias is always towards the null value. Okay, it's no problem. And then another example. Okay, we can have 50%. Now is 50% exposed. Means now we can have exposed or unexposed. Even if it is equal on both this side, then it's still okay. not exposed alone, but unexposed also. If it is equal on both sides, yes. Because you have to say the sensitivity and specificity of your instrument. Let's say in malaria, okay, we use a rapid diagnostic test. Let's say for falciparum malaria, let's say alone, and then the company will say that your diagnostic sensitivity is okay, is 90% sensitivity, and then you have 99% specificity. Then you know that all the malaria cases are not going to be classified correctly, right? Positive going to negative, negative to positive. For example, you know already what is the probability of disease given that you are having malaria. You will miss, let's say if the sensitivity is 80%, how much you will miss, okay? And then you will be misclassified. So we can put the sensitivity and specific context, and then we can think that, okay, how likely we are going to misclassify, okay? And then you know that your bias will be non-differential. You know from the beginning, if you don't have a perfect sensitivity and specificity, you know already that your OR will be underestimated. And then you know that you're not overestimating. Whatever you are reporting is still under, okay? So you are not going to exaggerate, but you are under. So when you write the paper, you can tell also that you based on this diagnostic criteria, our study are likely to have non-differential misclassification, but it's not a lot of big problem because we are underestimating it. Okay, it's not that we don't have, we don't have a perfect, unless that you have a perfect diagnostic, let's say PCR, you are sure that your PCR is 100%. It's still also, we are not 100% sure, you see, but few cases is fine. It doesn't make a lot of difference. Yes.
For the sample size calculation already, does it make, so we got the sample size that have been, let's say, think about the sensitivity already. So this is also made the non-differential.
Yes. If it is not 100, the reason sample size is nothing to do with this one. It's a wrong classification. Let's say you have the, I will show you here. First, it is about the validity. It's not random error. Sample size is for random error. You are answering the wrong, the different part. What I'm talking about the validity of your study. I'm just saying that your information should be accurate. But your sample size is about your random precision. Okay, it doesn't make perfect. Let's say if you use clinical criteria, you calculate the sample size. So what? You can have 3,000 sample size. But when you say clinical diagnosis, the sensitivity for clinical diagnosis is 70% accurate. Let's say if you use tourniquet test, platelet count, and hematocrit, you get 78% correct that you have dengue. But you never detect the virus. You do not use the NS1 antigen or IgM, okay, which have more sensitivity and specificity. So it doesn't matter, because we want you to tell, if you have dengue, please tell me that you are dengue by your measurement. If I have dengue, let's say, if I have a non-differential, non-differential dengue, okay, I have fever and other things, I don't have very severe symptom. I come to the hospital, you are the pediatrician, you are the clinician, you do not use any diagnostic test. You look at me, I say, oh, fever, like a viral fever. You never tell me I have dengue. I say viral fever. I have dengue, in fact, if you check my blood. But you classify me as non-dengue. So it's validity. I should go to this cell. I should stay in this cell. Because of you, I'm in this cell. I'm just saying, you are the PI. That's why I say because of you. You see? So this is not a question of sample size. I can have less, but it's more accurate. Enough sample size is happy for me already. I don't have to calculate. If you look at the sensitivity and specificity, you will see that what is sensitivity? Sensitivity is that the probability that a test will give a positive result if I am diseased. What is, if you say 80%, it means that the test will give a positive result. Only 80% of the time if I have the dengue. What about 20%? 20% will be gone somewhere. It's not in this true positive, only 80. Another 20 will be here. Okay, we call that false negative. You are positive, but you should be positive, but you are classified as negative. So issue is validity and issue of random error. Okay, sample size I told you from the beginning. Sample size can take care of random error, but not systematic error. This is systematic. So let's say if I put, this is too complicated slide, but I would like to show it to you that we can use software to take care of information bias. Let's say if this is the true population. Okay, from that table, it's complicated, take time to explain. So I come to this 2 by 2. So I have this is true, I calculate the odds ratio. Odds ratio is, you are from Thailand. What is the odds ratio? Say in Thai. C. Very good. So she can speak Thai. She got her MPH from Hindon University in 2006. 2006? 7? Okay, 1. So you're supposed to study for 1 year, but she studied for 2 years. So 4. No, I'm just joking, Don't be serious. So the true value is 4. Now what happened is that I'm trying to say that if the sensitivity and specificity of your diagnosis, let's say you have 90% sensitivity and 80% specificity for classifying your exposure status of the true population. I'm using the software because this table is a little bit deviated. So I can recalculate. So 50 become 55. Yeah. And then here 50 become 45. And then you look at the number again here. And then when you calculate the odds ratio from 4, it becomes 2 point something. Can you see that? Now I would like now the statisticians are better today. They're trying to find the statistic way to say that how much bias that you have done, how many % bias. It will come out like that. Okay. So during my study, I will stop here already. Okay, during my time at that time, I will say, okay, that is a non-differential misclassification. I underestimate by how much, and then stop. Okay, I don't know beyond this point already. But now the statisticians are very active. They call sensitivity analysis. They're very active. Now they tell me that if I know sensitivity and specificity, don't worry about the command, but at least you know that there is a way to calculate it. Very easy. We call sensitivity analysis. It's available. You can put the number and then they will do everything for you. Don't have to worry about it. So now that number, can you see that 2 by 2 table? I put the number. I put this is we call sensitivity. Okay, for the case, and then specificity for the specificity for the control. Case and control, I put it 0.9, 0.8, okay, and 0.9, 0.8. You see, 90%, 80%. And when I put this one into the sensitivity analysis and ask them that if my instrument have only 90% and 80% sensitivity, okay, what kind of misclassification will happen to my data and how much bias it will generate? It will tell me with this, your study will be misclassified and have bias of 41%. Can you see that? I never have this number. Now you can have this number. Okay, just to give it to you so that you can think about it if you want to do something. Okay, that is available everywhere. But it's not everywhere. But I'm just saying that it's now it's available. It's not like before. Okay, you can have this. So therefore, this will be called epidemiological sensitivity analysis for misclassification. So if you search this, it will be available. I think in R also available. Okay, this is I'm just showing you in startup. Okay.
So what we have with the percentage of the bias, is there any acceptable?
No. We will not, we just know that this is underestimate the true effect by 41%. So what happened? You can go back. If you know sensitivity and specificity. So once you know the sensitivity and specificity of your, this one, because this is your table, right? This is from you. You collect this data. You know the sensitivity and specificity of your test. And then when they say 41%, you can go back to generate this table. You add 41% to be perfect. And then you regenerate this table by yourself. And then you tell that I missed that one by this much. And I'm underestimating it. In the past, you never know about the true value. But now I can from my example, I'm trying to make inference to the population using the sensitivity analysis from my sensitivity and specificity of my instrument. If you know about your questionnaire sensitivity and specificity, if you know, otherwise you have to guess. Okay, and then you can say, but if it is equal on both sides, I'm just trying to give you that if it is equal from both cases and control. Okay, on exposure on the cases and control, or disease and non-disease, whatever it is, cohort, case control, design, then you can tell roughly. This is the statistic way. It's true or not, I cannot tell you, but this is the way they make their software available. Tomorrow the statistician will come. Okay, I'm not the statistician. Okay. So just to tell you that it's available. And the non-differential misclassification, it depends on the sensitivity and specificity of your. When you look at this table, you can see that depend on the prevalence, sensitivity, specificity, and the observed odds ratio. Okay, will be always towards the null value, and then it varies. Okay, with the same data. Same data with the different sensitivity, it can improve your misclassification. So when you design a study, make sure that you know about what is the, let's say if you're going to do some study on certain disease, on certain exposure. Okay, let's say you would like to have a chest X-ray. Okay, what is the sensitivity of the X-rays on detecting the disease? What is your biopsy sensitivity and exposure? So that is about the non-differential misclassification. Is it okay? Remember, I told you, remember, non-differential misclassification, bias towards the null. Always underestimate. Not so serious, but not so serious. Because you know that you know the predictability of your direction, because the other one is more serious because you cannot predict it will go right or left. It can go both ways. That is a problem. Okay, now it's differential misclassification. So the differential misclassification I put here is not equal when you classify the exposure based on disease and no disease, or you classify disease based on exposed or not exposed. It's not equal. Exposed different from not exposed. The sensitivity is different. It's not 80 both, 90 both. Okay, so it's different. So let's go to example. Okay, so it can cause why it's so serious? I told you the bias of differential misclassification can be towards or away from the null value. Okay, and this is the serious one, okay, that you have to consider. Next one. So it can be towards or away, depend on the conditions. Okay. We will see example first, and then we can come back. So both the cohort and case control study, and I would like to show you the example first. Let's see this one. Okay, of differential misclassification. Look at this table. Okay, so differential misclassification, overestimation of exposure among cases only. You see, you have cases overestimate, but control not over. In the past, we have 10 both sides, but now 10 on case, but control no problem. So only the case. So it means that it's not equal overestimation or whatever you apply. So when you calculate the odds ratio, you see now in this case is away from the null, not towards the null. 2 to 2.8. The second one. Now over, same thing or not? So this one is not over but lower. Cases become lower. 10 cases. Just now that I put cases 10. Now I put lower. Okay. So when you calculate again, now is 1.5. Okay. When you decrease the case, instead of deflate the case, but only the cases. Or you can have only the control, not the cases. So now it's become 0.5. Now it is not away from the null, but it is towards the null. Okay. So therefore, it's a problem. Now you go back to the control. Okay. The control can be underestimate, can be overestimate. The same thing that I'm mentioning. Okay. So you can look at the slide. And then now the control can be, if you increase the control, it can be towards the null or away from the null. And then if you're going to use the software, let's say if you have sensitivity of 90%, 96%, and specificity of 100%. Okay, to see what happened to our bias. Okay, for the control is different. For the control is 70%. For the cases is 96% sensitivity. And then for the control is 70%. In the earlier case, it is 90% for the cases. Okay. It's the same on both sides. Okay. And then for control is some what is the percent? I forgot. Can go back and see. Sorry, go back in order for you to make it more understand. So it is the 90%, 80%, 90%, 80%. Can you see that? Both cases exposure, but this time I make it differential. Okay, make it different to become 96% and 100%, and then here is not the same anymore, 70 and 80. So different from the cases and the control. And then when I do with the data, I do the sensitivity analysis. Can you see that? Sensitivity analysis. Okay, for differential misclassification. Then we see that we will still have our true is 4, still the same. True is still the same. So now we have 46% bias. Okay, so it's still biased, but this one is more dangerous. So just to tell you, so this particular part is the conclusion of this part is that non-differential and differential. Okay, it can be away from the null. So you can look at the exposure or outcome. Okay, it will be both ways. So this is my kind of very quick. In fact, you should go more detail, but we don't have time. So therefore, we late from the beginning, and then we have to finish very quickly. Okay, because I heard that your transportation will be finished at 4 o'clock, right? You will not have a bus to go to the hotel.
Anytime, you said 8 p.m.
Huh?
Ajahn said 8 p.m.
Are you sure you will be alone? Everyone will be gone, including me.
I have a question.
Yes, please.
In total, we're gonna act like a mentor, and do we need to check all like non-differential misclassification from the data?
At least as a mentor, we would like them to have at least the design is a kind of the publishable and then can be disseminated. Whether you are, I don't know whether the one that going to be working with you are you going to ask them to present the data in the public forum or not? What is your expectation? For example, our student, we want our student to be able to go to the conference at least, and then stand there and tell that, oh, I have conducted something that I have a data, surveillance data, I have a things, and then I don't want that the people who listen and then try to tell that what are you showing, a mosquito net is a risk factor, something like that. I'm just trying. What is your expectation when you give a mentoring to the student? You want them to communicate. You want them to have the characteristic to present some valid, some interesting, at least not perfect. I'm not saying perfect. At least something is reasonable, scientifically valid, epidemiologically, something that is some. It depends on expectation. So at least if you are as a mentor, you say that our student having this one, they are using this diagnostic criteria for classification. They're using this instrument. For example, if you use certain instrument, is already available information. For example, standardized questionnaire. Standardized questionnaire developed for this one is already available. Let's say breast cancer assessment, or let's say, I'm talking about the human part, but I'm saying the veterinarian part, if they have some kind, then you know the sensitivity and specificity. And then you will think that, this likely to be, whether it is the older animal, disease animal or normal animal, when I look at the exposure, likely that they should be the same. And then I think that the bias, if it occurs, it's likely to be non-differential. Or it's likely to be differential or not. So if you suspect that it is differential, then you have to be concerned that this may be a problem. Okay, that's at least you are aware of. So when you design a study or design a project, then if you are aware, at least you are aware that whatever happens, I would like to make sure that it is a not differential misclassification, because it can be done with different diagnostic tests. You use a different time. Sometimes you say during 1980 to 1985, you use one diagnostic test, and then you wait, okay, in your archive, in your recording, in your surveillance system, and then 1990 to 1995, they use another diagnostic test for another one. So you have to differential diagnostic criteria, and then you would like to put them together. You got my point? And then you start scratching your head. Hey, can I have a data that use a different diagnostic test combined with another diagnostic test, and then to say that this is the same disease? If you do like that, then you have to suspect that. Then when you design, you say, okay, I will have only 2009 up, because they say use the same diagnostic test. I will confine my thing in order to have a uniformity of my design. If you think like that, then it's useful. Otherwise, when you know about differential, non-differential, and then you are not apply that one, then it's not going to be useful. But this may be useful to you to have that, hey, I'm aware this is serious. differential misclassification should not occur in my in my report, because this may be our methodology should be protected. That's all. Yes, please.
Yeah, just a quick question. So that means for all mentees, if they want to, if we can estimate the differential misclassification, so that means we need to let them to adjust when they're reporting the findings, right?
Like to recommend not this stage. This stage will be for our knowledge. But I'm just saying that you can do, but I would like you to design to prevent it from the beginning.
Yeah.
Before you collect the data.
Mhm.
If possible, because this is not correcting this one is just to tell us how much bias we have already done. You got my point?
Yeah,
You already-
absolutely,
So
absolutely.
yeah,
Yeah.
then I have a problem. But this problem cannot be corrected because the data already collected. Sample already classified.
Mhm.
So I want you to think from the beginning. For example, just example of selecting the data,
Mm.
mixing different diagnostic period and this and that. So if you design from the beginning, then you say, I would like to avoid differential misclassification. I would like to have the diagnostic test that apply equally for both my groups and also to be the same period. I will not use two diagnostic tests. If the doctor is going to be diagnosed, I would like the doctor to be uniform, to be trained first, to understand about the criteria. Rheumatic fever, you see, so long the list of criteria.
Okay.
One doctor will say something, one doctor will say something. Even the sore throat, you open your mouth and ask doctor to say, is the sore throat or not? The redness, people will say because of the light from the battery is not red. This one is red. Say it's the redness is 1+, 2+, 3+. Who can tell? Is the 3+? Even the same X-ray, they have done the study. Same doctor reading the same X-ray 3 times. Agreement only 68%. Same X-ray, same doctor reading. Today, the reading. But AI is always perfect. You ask AI to read every time, everything the same, never different. We don't want to hire any doctor anymore.
So that means is for the study design, we should encourage them to avoid misclassification as much as possible.
This is the very good summary from you.
Can I ask, for just in case, because sometimes we can't prevent all the bios, we just try our efforts to mitigate the bios. But in any case, if they calculate those percentage, they can quantify what's the percentage of this differential classification effect. Is there any kind of the cutoff, say, okay, which percentage is more acceptable, which is not?
Validity will not be tested by statistical test, any test. But after I tell you confounding, I'll tell you a little bit. So there is no statistical test to tell that 5% different is different or not. It depends on the context. If you're talking about the death, 0.5% decrease in death, 1% decrease in death. Let's say now we don't have a survival for rabies. Almost 100% dead, most country. If you're diagnosed as rabies, you can expect already going to which temple, you have to book already, right? But you have some new drug coming up, let's say something, and then you say that I can cure, I can put 1.5% of all the rabies, although 100%. And then you have out of every 100 cases, less than 2 cases survive. As a veterinarian, as a physician, as a public health people, you think it's important or not? Only 2 cases out of 100. But it's dead. But if it is hookworm, I have a new from papaya leaf extract. If you take this one, out of every 100 cases, 20 cases will be okay, will be cured. Success rate 20%. Hookworm. I have so many drugs. Mebendazole, Okay, albendazole, this one, that one. You see? So it depends on the quantity. Even 20%, I will say I have better one. But for that, okay, even 2 case, 3 case, maybe you will be proposed for Nobel Prize. Okay, if you could make somebody survive from rabies. So therefore, selection bias, information bias should take care at the design. Minimize the bias, cannot eliminate all the bias. Minimization. By aware of all these kind of problems. Selection, what is the problem? Selection of control, selection of the sampling frame. You have a sampling frame, method of sample size, okay? Estimation for random error. And then this is for the systematic error. So confounding. Hey, break. You want a break? I feel that you may be a little bit tired. I look at your eyes stand. It's now smaller than the morning. So when you come back, you can close your eyes but open your ears. Okay, and go. See, look at the dog there. I purposely putting for you. Confounding means confusing. See? Okay, we have a break and we come back. So before we go into the definitions and the concept and how to assess confounding in our data, I would like to show you about usually when we do not think about the confounder and look at the very crude data, when we look at the crude data, sometimes it may be confused or we may interpret and conclude it wrongly. If you look at this graph, very simple graph, is 2 dimension. It's about the prevalence of Down syndrome at birth. This is the data that they show that if the birth order and Down syndrome, if you are child number 1 and then child number 5, what is the prevalence of Down syndrome? Okay, my family have 10. Okay. Those times they have many children. So I'm number 6. My probability is something here. Likely to be Down syndrome. So if you look at this data, what is your conclusion? We'll make when they say that there is likely to be the trend. The trend is very clear, right? The trend is very clear that Down syndrome likely to be associated with the birth order. If you are child number 1, you are likely to be less, the prevalence is lesser than the number 5. Is it true? Or it is something else? This is about the confounding. What you see is not what you see. Okay, it's something else. So we have to untangle something that is explaining this picture. It's not about the birth order, but it may be something else. So if I ask the question, I'm thinking potential confounder, something that may be confused this association. Let's say mother's age. If I bring another variable, mother age, I put mother age this side, birth order that side. Okay, mother age is here. And the birth order is this side. What do you see now? Birth order and then the mother age. Is there association of the birth order and Down syndrome still there or it's gone? It's gone. Because you see whether your birth order number 1, 2, 3, 4, 5, it is the same as age number. As age less than 20. Even age 40. It's not different by birth order. The association of birth order disappear. Totally disappear when you consider age as the third variable. Third variable, or we call the extraneous variable. Okay. They use this two words, extraneous. Third variable. Extraneous means extra, something that is not. So what we are consider exposure as birth order, and our outcome is Down syndrome. Third variable or extraneous variable that is likely to be confounding factor is age. And what is their characteristic? We will see in a minute. Now, can you see something that is not straightforward? Something hidden behind the scene. If you don't pull that variable into the open, you may be biased, okay, by the confounding factor. And confounding factor can be so many mixed. It can be many factors together working, not only one at a time, maybe 2, 3, 4, 5, 6 simultaneously. And how can we taking care of confounder? This part, everyone must consider seriously, okay, in the analysis, at least in the design and analysis. So this is about this one. So what is confounding? Confound, if you open the dictionary, of course, it means confusion. It will confuse your view, confuse your understanding about the association of the two variables. So I say mixing of effects. What I mean by effect here, what I mean is the exposure and also the confounding factor, everything mixed together. And then we don't know what you see is due to the third variable or it's due to the exposure. It's a mixing of the effect of exposure. Okay, so the estimate of the effect, your odds ratio, your relative risk, your prevalence, your incidence, anything that come out, it is mixed, okay, with the effect of exposure. Okay, the estimate of the effect of it is being mixed with the effect of the third variable. Okay, this is the definition. So it is mixed with the effect of the extraneous variable or extraneous factor. If you imagine, everything you see is not what you see. It is maybe contaminated. Think the odds ratio, single summary odds ratio, crude odds ratio is, we will see what is crude means. Whatever you see, you have to see, this is contaminated. How I'm going to purify it? What you see is crude, not refined. So if you remove all the confounder out, then it becomes refined. It becomes purer. Not perfect, but purer. Okay, and you will see how we're going to make it better and better, okay, for your estimate. So like this also, so you see that our exposure interest is this one, coffee and hard, and the smoking maybe a confounder. Why? It's a confounder, we'll see in a minute. I'm just trying to say that when you don't see this hard, you may be thinking that it is the effect of the coffee drinking. Now I would like to define, okay? So I would like to say that the confounding can distort your relative risk, okay? And then it will can also change the direction of your estimate. It can be make it all away from the nulls towards the null, okay, or switch over on all the sides. We will use alcohol, smoking, alcohol and oral cancer as the example, and then we'll show you in the multivariate analysis. So let's say this is what I would like to show it to you, that this is very common. When people drink, they smoke. And then when the people smoke, they also drink. Okay. When compared to the people who do not drink, they are not likely to be smoker. And if they are not smoker, they are also not very likely, less likely that they will be drinker. There will be some who do not smoke and drink. So therefore, when we are studying, okay, now I'm going to put the picture in the 2x2 table. I'm not going to put as a number for a minute. So when you label as exposed and unexposed, this is the study between alcohol drinking and oral cancer. Okay, alcohol drinking and oral cancer. So when I say alcohol drinking on this side, this side of 2x2 table, everyone on the right hand will be holding glass, right? Because exposed. And you look at the non-exposed, nobody is holding glass. So exposed compared to non-exposed, okay? Very clear when we put in the 2x2 table. So that's why you can see what is behind the scene. Now, okay. So that is the picture we see. Now, before we are going to see the more details, I want you to see this side also. Sometime when we say exposed, not exposed, everyone hold the glass this side. But who smoke and who do not smoke, you do not see. You did not see in the 2x2 table, right? You did not see. And that is the point of confounding. That somebody who also drink and smoke, when you compare to this side, and this side smoke less than this side, the effect that you see, is it from alcohol or is from the smoke? Do you know? We don't know. Unless that we remove the smoking out, then we will know what is the effect of alcohol. Our purpose is to estimate the effect of alcohol without contamination by smoking. We want to remove smoking out because our objective, our hypothesis, our research question is effect of alcohol and oral cancer, not smoking and oral cancer, but smoking is contaminating our estimate. So we have to remove it. Now, what is the characteristic of confounding? One, to be a confounding factor, you must have at least two characteristics here. Very important. Three or third one also okay, but at least two. A confounding variable must be a risk factor of the disease. Okay, if that factor is not a risk of the outcome, that is not going to be likely to be a confounder. The second criteria, a confounder must be associated with the exposure of interest. Okay, must be associated with exposure of interest. I will come back again here. Let's go back here first. You look here. Three situations here. E is exposure, D is disease, F is confounder, likely to be confounder. This is likely to be a confounder. Below here is not a confounder. F is not a confounder. At least potential confounder is here. What is the first criteria? First criteria is F must be a risk factor for disease. Okay, let's say oral cancer, drinking, oral cancer, and smoking. To be smoking to be a risk factor, it must be a risk factor of oral cancer. So smoking is a risk factor. If you smoke, the incidence of oral cancer is likely to be higher than the non-smoker. So the first criteria is fulfilled. First, F and D should be associated. If you do the chi-square, it will be associated. The second criteria, E and F also must be associated. Mean that if you drink alcohol, you are likely to smoke more than the non-drinker. Okay, smoker and drinker go together more than non-smoker and drinker. You got my point? Means an unequal distribution. That is an unequal distribution between smoking on this side and on this side. Those who drink smoke more than those who do not drink. You got my point? That is the association between exposure and confounder. Means that on both sides is not the same. If it is the same, it's not a confounder because all the factors are the same. Okay, no contamination. Up to here, any problem? Are you okay? Or are you KO?
Okay.
Okay, no? So two factors must remember. One, to be in your study, when you conduct a study, when you tell your student, to your mentee, then you have to look, when they design a study, you have to say, please collect the potential confounder. not collect everything under the sun. Okay? There's so many things under the sun. Collect everything. Maybe a potential maybe a confounder. No, you will collect only from, you review the literature. The previous study say that this is a confounder. Then you can identify the additional, the one that they already done, you can put it because they prove it already. Then the one that is potential, means if they have these two characteristics, age is a confounder, is the income a confounder, is that other behavioral or other things that may be a confounder, please put it, collect it. If you don't have it, you cannot analyze. Okay, so in the design, you have to consider this one. Now, so all these three situations, if I show it to you, this one, this is a confounder because it fulfills the two criteria. This also fulfills the two criteria. This also fulfills the two criteria. Okay, so, but look at this one. Is F a confounder? F fulfill one criteria only. It is a risk factor, but F is not associated with, not collect it, waste of your time. When you come, it will not be a confounder. Okay, so this is the kind of the minimum thing that you have to consider. And the third criteria, I did not tell you. The third criteria also, so if where is the, this one. The third criteria is that it's not, should be the intermediate variable between, should be not the variable between the causal pathway. Okay, so let's say if you have stress, if you would like to study the stress and abortion, okay, study stress and abortion, then the intermediate variable will be the hormonal change. If you control for hormonal change, then the association will disappear. Okay, so that is not, should not be controlled because it's a pathway of the stress. So we call the intermediate step of the causal pathway. Okay. Once this is clear, then we come to the how to assess confounding. We will show it to you, and if possible, you should look at this one. This is an important one. So today we will calculate something we call crude relative risk. Okay, crude, everything crude. Now what is crude? Crude means that everything is collapsed into one estimate. Okay, everything not stratified, not make it different into groups, into strata, into stratum, whatever it is. So we have a crude. So your eyes, now you remember first, if I want to know whether there is a confounder or not, confounding or not, I have to look for one, crude. Where is crude? And two, I have to look at adjusted. Okay, just remember first. I have to look for crude and I have to look for adjusted. If I don't have adjusted, I have to find adjusted. Okay, I have to make sure that I have adjusted and crude. And then when you have adjusted and crude, then you compare. Compare what? Compare crude and adjusted. If it is different, if crude and adjusted different, then you can say the variable, that the third variable, because we are not talking about exposure and outcome. We are talking about third variable, extraneous variable. Then we can say that extraneous variable is a confounder. Okay? Let's go. And then how much different is different? Let's see. Not now, just take the word different. So how can we taking care of confounder, control of confounding? There are many ways. In the design, when we design the study, and then when we analyze the study. When we design the study, we can, during the design step, you can do matching. Okay? Case age 50 to 54, control also age. if we think that age is a confounding factor, then you match from the beginning. If gender is a confounding factor, then you match it. If income, gender, occupation, education level, whatever, but the most important one you can match. When you match it, then they're likely to be similar, okay? But do not overmatch it. If you overmatch it, you will have a problem of overmatching, and that is bad also. So therefore, you have to match. You can have a pair match, pair to pair, group matching. Let's say if I select the 5 cases, I can select 5 control, not a pair match, but okay. You can select the control that have the age similar, okay, not perfect, case by case. Today, what I'm going to show you today here, restriction is that when you design it, you can restrict that I will select only non-smoker. If I think that smoking is a problem, I can select. But the problem of selecting only one group, you will have a problem of generalizability. When you get the result, then it is good for the non-smoker only, restricted population. You cannot generalize to larger population. That is a problem with the restriction. Okay. So today, what we are going to do is stratification and mathematical modeling. Okay. It looks very scary, huh? But it's not that difficult, huh? When you see the statistician, Dr. Charanit, in the next 2 days, maybe he will be telling you a lot about this one. So in the analysis. So what we do now I give you this example. Now we have a 2x2 table. 2x2 table. This is a cohort study. Follow for 10 years. Okay. And then we have alcohol there, oral cancer this side. We calculate the relative risk. Okay. How we calculate the relative risk? Now, first you calculate the risk among exposed. Risk among alcohol drinker is 200 divided by 1,000. So it is 20%, right? This is 20%. The risk among drinker. The risk among non-drinker is 5%. When you divide this risk of exposed divided by the risk among unexposed, then you see relative risk equal to 4. So how you interpret 4? The risk of oral cancer among alcohol drinkers is 4 times greater than non-drinkers, right? We have 4 times greater. And I put the word crude. Crude is here. This is what you have to look for in the assessment of confounder, this number. You have to look something we call CRR, or crude relative risk. COR, CRR, whatever it is, is crude. So this number is necessary for you. Okay, look at it first. In the starter, I will do everything. Enter this 4 number enough. It take about 21 seconds, 1, 2, 3, even less, maybe 16 seconds. Okay, and then everything come out. Everything. Okay, don't need to do anything. Only this number, and then tell them that this is equal to 2,000 observation. You can tell Stata, you put this one, and then you can tell Stata also to make the raw data out of this. Stata will understand and will generate 2,000 record for you. Okay, how to do it if you want later on. So therefore, I go now. I think that now I put this 4 number. You can see that? Not 4 number. In fact, I put I put 4 variable. Okay, I put 3 variables: OC, alcohol, and count. I can code this, okay, into 3 variable, and then I can make statistical analysis already. So quick. In the past, it's not possible to make this quick. So now I put the same thing. I got, what is my risk ratio? What is my relative risk? 4, right? And then you can see every chi-square. If your brain knows, your eye will see. You see what you should see? First, crude. What else you should see? You see, they calculate the risk for you. 20%, 5%. Then you look at the confidence interval. What about the confidence interval? Tell me about this confidence interval of relative risk equal to 4. When you see it, are you excited to see what happened to this confidence interval? Precise or not? Is the study precise? Right? Narrow. Include, what about the one is included or not? One is not included. And then the estimate is, you can guess around here. You see? Everything is here. This is a simple, a kind of the data analysis. Now I would like to, I already know the crude. Now I would like to, what I worried is a smoking. Smoking is my potential confounder because smoking is associated with the risk of oral cancer and also associated with the alcohol drinking. So now I would like to stratify. I would like to split this table into two tables, smoker and non-smoker. This is the smoker, this is the non-smoker. Okay, I would like to split it. Okay, so and then I would like to know what is the relative risk among smoker, what is the relative risk among non-smoker, smoker and non-smoker. And I would like to calculate something I call adjusted. I told you when I was have to do this study, I have to use calculator, Casio, special type. Take very long time before I could do the chi-square. I have to write the formula, this and that. Now, nothing. So now, and then we will come back to this table again. We go here. Now, we calculate now. Okay, let's make it clear. So what is my crude? My crude is 4. What is my adjusted? Quickly, and then we will go to interpretation. I want you to interpret more than assessing this. So now what you see is that when you control by smoke, you separate to smoker. So everyone a non-smoker here. Everyone is non-smoker. Everyone is smoker here. And then you calculate what we call a stratum specific relative risk. This is called stratum specific. This is specific for smoker. This is specific for, remember this one. Why I want you to remember this one? Because when we talk about interaction, we will look at this also. Okay? Don't forget this one. Now we don't want to go into this a lot. So let's see that, let's say this one. So here I interpret this as the risk of oral cancer among drinkers is 4 times greater than the non-drinkers. How do I interpret this one? This 1.13. This is important. Now there is a difference. Difference between 4 and 1.3. No doubt about it. It's very clear. So crude and adjusted is not equal. Crude and adjusted is not equal. So how we conclude? Is smoking is a confounder or not? You should say yes. Because crude and adjusted is not the same. I told you how we assess confounding. When crude relative risk is not equal to, even if you sleep, you should remember this one. Okay, so now smoking is a confounder. So which one is the more correct estimate? 1.13. Because 4 is contaminated by the effect of smoking. The effect of smoking is mixed with the effect of alcohol in the beginning. When we remove the effect of smoking, the pure effect of alcohol is only near the null value, almost 1. So it's no effect at all. But if you don't remove the effect of smoking, you will conclude that it is 4 times. Now, what is the meaning here? when I interpret this, you have to report this in your final analysis. After, now interpretation, after adjusting for the effect of smoking, after removing the effect of smoking, after controlling the effect of smoking, the risk of oral cancer among drinker and non-drinker is almost the same. You got my point? In the crude, you say, wow, significant. Everything's. Now I use Stata to analyze it. Stata, okay? Stata can analyze it. You can look at this. Now I enter the data. Only 8 observations from that 2x2 table. Stratified, right, left. Okay? This thing come up. So I have, this is crude. 3 minutes, not less than that. 4 and 1.3, you see? Stata say crude, Mantel, Hansel, combined. This is the adjusted. Now, please, everyone, look at the confidence interval. Look at the confidence interval of crude and adjusted. Compare the confidence interval of the two and then the meaning. Please tell me, what is that meaning of the confidence interval of 1.13? Now it's not significant, right? Here is significant. Without adjusting for smoking, you go to celebrate already. Hey yo, okay, 4, I can publish already. But when you come back, okay, after today studying confounding, go to adjust this 1.13. Confidence interval different. It's not significant anymore, but it's okay. We can tell that you can drink. No. It's wrong, still wrong interpretation. Okay, I will tell you why not. So therefore, if you look at the chi-square, this one, you will look at the interaction. Okay, remember, you will look at this when I come back to interaction, same thing here, and then we will interpret. So for the confounding, you will see that this is the stratum specific relative risk. We will look at this and this, and then we will have a lot of example. So confounding. So when we see the first question is there a significant association between disease, exposure and disease, or alcohol drinking and oral cancer? Yes, we saw in the crude analysis 4 times. But we say that this is not yet finished. We have to go further. So we go further to take care of the confounder. So this is one example that I use smoke as the confounder. And then we say that if you don't adjust, you will have a problem of bias. So the bias will be away from the null here. True is 1.13. True is 1.13. Estimated from your data is 4. So if you don't control for the confounder, the bias will be away from the null. In fact, it should be only 1.13. Okay? So therefore, how they calculate and all the thing, I don't think you need to know. Okay, Mantel, just to know that they use weighted average. Okay, weighted average here means that they use from this to stratum. You see, from this one. So it's not, there are ways to average it. 1.12 and 1.86, they average it, but not divided by 2. There are many ways to do it. So they use the technique we call Mantel-Hansel weighted average of the 2 strata. Okay, and then they get 1.13. How they calculate? If you want to know, it's okay. But I don't think you want to know. Okay, I have also provided how they calculate. Okay, from this ABCD, how did they calculate? Because I have to follow this formula. Otherwise, I cannot get the adjusted when I was studying this one. So don't worry about it. For case control and for relative risk, for odds ratio. And then, so this is the stratified analysis. So stratified analysis is a straightforward, okay, of the analysis. And so you can see the number, you can see the average, the table, you can So it's easy to understand for those who are not being exposed. Another thing is we call degree of confounding. Degree of confounding means that you divide the crude by adjusted. If you don't control the confounding factor, you will overestimate. Okay, you will overestimate by 3 times. Okay, you can divide this. It will be 3 point something times. So okay, crude divided by adjusted, it will be 3 point something times. So whether you're going to this is just for understanding, don't worry about it. Now you tell me, okay, quickly. This is the data stratification of the exposure is the MI, myocardial infarction. The exposure is oral contraceptive. Okay, exposure is oral contraceptive. And then we suspect that age is a confounder. Okay, age may be a confounder, maybe. Okay, now you look at this table and tell me whether age is a confounder or not. And then what you see on the OR there is a case control study. So that is a stratum specific odds ratio for each age. Now you tell me, is age a confounder? And then we'll bring back this data to see whether it is there is an interaction or not, okay, between age and oral contraceptive later on. Is age a confounder? Look at what I told you, what to look for when you are looking for confounder. What your eye should look for. First, look for what first? Crude and, yeah. Did you see crude? Where is crude?
Not sure here because.
No, not sure. No, you have to be sure because it's already there.
Odd ratio.
Yeah, odds ratio. What is the number there? Crude is equal to whether the crude and adjusted same or not. What is crude? Where is the crude here? Where is the crude here? Eh? Crude you know?
1.7 เหรอ
Crude, very good.
1.7
Why it is 1.7? Tell me. Why crude? This is the total. Crude is not by category. This is a stratum specific. So when you combine everything, then this become crude. What is crude odds ratio?
1.7
How you calculate AD divided by BC, right? Then you get this one. And then you compare where? Compare with adjusted OR, mental Hansel. You average this, okay, by mental Hansel technique to get 3.97 something. Then you compare. And then you say age is a. See, so quick. This is by stratify. Stratify is everything you can see. But when you do the mathematical modeling, then you cannot see so much. Okay? Because it's a little bit complicated. So let's see the mathematical modeling. Okay? When we we'll come back to the residual. Yes.
Can you go back to the table?
Because the stratified age of each age group, it shows different odd ratio, right? And you use the calculation to get the MH odd ratio. Is it correct?
Good question. Very good question. I don't want you to ask this question, but you ask it. Very good. So I'm just saying that because I have not teach you interaction yet. So that's why I'm just saying that the first step, and then I will tell you, as you mentioned, you're right, that we have to be very careful. Why we have to be very careful? As she mentioned perfectly. This is 3, this is 7, this is 8, this is 1.5. Is this different or not from each other? If it is different from each age group, means that this age group is different from here, then is it correct to combine? Very good question. Okay. So I will come back to this again to tell you that when should we combine? Now, when we combine, it may not be correct. Now it may not be correct. But I'm just showing to you, if you do the confounding, what you see, if you see, even if you see crude and adjusted, you may not likely to compare, because when I teach you interaction, I will ask you to do interaction before you think about confounding. You got my point? So, okay. Yes, I will answer you after a while. Very good. So now I will skip all this first. I will go to some of the data, some of the multivariate. Let me see, where is that? Oral contraceptive. Let's say oral contraceptive, and the same thing there, and minor and MI. This is a published long time ago, but it's a good data. That's why I bring it for you to see since 1929. I want the old data there. Okay. So what happened is that now if I use this data, okay, this is a MIOC, and I would like to for you to see some of this. This one, right? Can you see this one? This is the same data as you asked. This is the MIOC, that's one, and age, by age group. So this is the different age group that you saw just now that I said. So strata have different age group here. So when you see different age group with stratum specific 7, 8, 1.5, 3, 3, 3.93. So what happened is that before that, I have to prove this first. I have to prove that this 78133 is whatever the difference you see is by chance or not. Is it because of it is totally different, or it is the random variation? So I need a statistic to test it before I combine it. As she mentioned, her question is, should I combine or should I not combine? So I'm going to do some statistic here to test this one. So I'm going to look at, you have to look this. This is a test of interaction. I did not teach you yet, but you asked first. That's why I bring this data. So test of interaction here means that whatever I see is the effect of oral contraceptive modified by age or not. Okay? If it is modified by age, is different by each age group or not. So from the test of homogeneity here, remember, don't worry, we will come back again. I will teach you. So it says that, what do you think? Significant or not? The p-value. So p-value says it's not significant. So I have to look at this first before I look at the adjusted. Look at the adjusted, same thing, right? 3.9 here. So I have to look here first. If the p-value is not significant, then I mean that I can combine. If it is significant, I will not combine. I will say something else. Okay? So that's why the reason I combine, because I already know that is not significant. So I can combine. So now I can compare crude and adjusted. So crude and adjusted is different. So I can tell now age is a confounder. Okay? Did I answer your question? So always you have to check whether the stratum 1, stratum 2, stratum 3 significantly different or not. Okay? If it is not different, then we look at adjusted. If it is different, now we talk about, okay, we forget about confounding. Confounding already. Make it separate. Then you will report your data separate. For each age group, for each category of smoking, or non-smoking this much, or smoking this much, or smoker this much. Okay? Now, yes. Yes, I will show you. I will show you the data where there is a positive interaction. Okay? Now I'm showing you that is no interaction. And then I can combine with the with all this data together. Yes. No. So interaction is a phenomena that you need to explain. You got my point? No, yeah. So confounding is a systematic error. So what happened is that when we are talking about validity, we don't have a statistic. We will not use the chance or random aspect to explain the validity one. P-value here is about whether it's different or not. It's nothing to do with confounding. Whether the number here, number 781 something is different by chance or not. That's why we look at this P. This P and that P is different. So this P is for homogeneity, is for the stratum specific. Okay. So nothing to do with confounding here. We just to say that, okay, the number, the different of age 1, age 2, age 3, age 4, age 5, different or not different. But we do not have statistic to test truth and adjust it. We don't have statistic because the concept is that it's about the accuracy, validity. It's not no statistic. It's talking about variability. So we are not talking about, so it may be because of the sample size in some of the stratum is very small, some is big. It may be different. So that's why we test it. Okay. So we will come back to this. All this is important, and then we will summarize everything for you. Okay. In the end. So let's go back, because she asked this question quickly. So the other aspect that you have to, I will go quickly, is something we call residual confounding. After you control so many confounding already. So let me show you the mathematical modeling first. Okay, you will learn it as a mentor. I think you need to know also. So here we are going to use, we call mathematical modeling, that stratification. Just now what I told you is mathematical modeling, stratification. Mathematical modeling. This is also not difficult nowadays. Okay, you can do with R and Stata. So here we use logistic regression. You can use logistic regression. When you do the regression, simple regression, your Y is a continuous variable. And then your X also continuous variable, okay, or discrete variable. But for logistic regression, your Y is binary. It's yes, no, disease, no disease. So they model as the log odds, log P1 minus P. Don't worry about all this, but ultimately it will be equal to odds ratio. Okay? It'll be equal to odds ratio. This one will be, you have intercept, you have beta 1 x1, beta 2 x2, beta 3 x3, whatever it is, and then you can put interaction term. So this is the exposure. X1 is exposure. X2 may be a confounder. X3 may be a confounder. So when you want, or X4 may be a confounder. When you would like to adjust for many confounder together simultaneously, in stratification, in stratify analysis, one by one, right? You do smoking, or you do age, one by one, one at a time. But one at a time, sometimes it's not good enough. You want 5 at the same time. You want age, occupation, education, genetic background, family history, everything at the same time. Then you have to go to mathematical modeling. Why we don't use stratify analysis? Stratify analysis is for 1, maximum 2. If you have more than 2, then everything becomes 0, 0. It cannot calculate the relative risk. But mathematical modeling take care of this. Will take care of many confounding variable at the same time. Okay? You can do, I'll show it to you. Very easy. Okay? Very easy. Not difficult. So something that you have to learn a little bit, okay, maybe 2 minutes, is even if you control for many confounder, still you don't know about the residual confounding. Something that you have not measured. You did not think about it. You did not put in the analysis. It may be hidden in your data. I have not measured it. I do not know about it before. So it's still, we call that as the residual confounding. And then, is it serious? Maybe serious. How we know about it? Yes. We try to know about it. Okay, how do we know about it? We can use E-value. Okay, we can use something we call E-value. Okay, E-value. For whether the E-value is maybe too much or not, I don't know. If too much, then we can skip it. So we can calculate E-value. E-value can be, you can go to the website. Okay, you can go to this website. You can go to, we call E-value calculator. Okay, you can check E-value calculator. And then you can put that you want relative risk. This one is, what is your crude? What is your point? What is your adjusted? Whatever the point, the estimate that you want to check whether still, is there any, let's say you can have 1.13 or 4 or whatever you can put there. And then you can put the confidence interval, lower and upper limit. Okay, and then the null value, that default value, null is 1. Relative risk. And then they will plot the graph for you. They will calculate the E-value for you. The higher the E-value, the likely that you will not have residual confounder. The smaller one will be likely because of some missing thing can create that. If your relative risk is only 1.6, very small relative risk, okay, E-value may be also small. So therefore, this is something that I want you to be aware of. Okay, because now many people are talking about residual confounding. They don't trust the small effect. Something is very small, 1.7, 1.5, 1.4, and then significant, because you have a big sample size. And then the effect is 1.52. So if small residual confounding may make that association disappear. So that's why that's one way that statisticians are doing is that calculating the E-value or residual confounding. Okay, just keep in mind. Don't have to worry so much. Now we come to interaction. It's already 3:30. Okay. So interaction, in fact, the other name also effect modification. Okay, interaction, the other name is effect modification or heterogeneity of effect. We would like to know whether for each stratum, each level of third variable, whether it varies among, or it is uniform, varies or uniform. If it is uniform, we say no interaction. If it is not uniform, then we say it's interaction. Okay, you will understand with the example. Let's go. So the interaction can be statistical interaction and biological interaction. Statistical interaction. What we are learning today? What we are learning today? You have a 7-Eleven? Can you see? Can you see at the back? Statistical and now it's better. You should give me long time ago. Biological. biological and statistical. What we are learning is statistical, based on the statistical model. Okay, so we have model here. What is biology interaction? You will see, which is things that cannot be assessed by statistical one. So statistical interaction here means that if you have the risk factor A, okay, and then you have the outcome Y, exposure outcome, E, okay, A or E and O, whatever it is, what you want to say. And then you have a third variable again, like that. But here we call Z. If you stratified it, or if you make it, okay, into groups or stratum or strata, whether it is homogeneous or not. When I say homogeneous just now, I mean that same, similar. It's not by chance. Okay, it is by chance or not. It is. If it is same, then there is no statistical interaction. If it is not the same, that is a statistical interaction. That's all. Okay, but the concept is very long. So today we have how we measure interaction. We measure by two scale. One scale we call additive scale. Additive. And then multiplicative scale. Additive and multiplicative type of interaction. Whether when you say you have interaction, statistical interaction, you have to tell it is based on additive or multiplicative. And if there is no multiplicative, you will have additive. And not additive, you have multiplicative sometime. So sometimes it's very confusing that is there, in fact, that there is interaction or no interaction. Because if there is no multiplicative, you will see in additive. So some kind of interaction will happen. So let's see the concept of interaction. It means that it can be when the two variables are together. When the two variables are together, the effect is more than the simple combination of the two. It's more like synergistic effect. Okay? Means that if A is 2, B is 3, when they are together, it's not 6, but it becomes 10. Okay? The odds ratio becomes 10. It's not simple multiplication or addition of 2 plus 3 or 2 multiplied by 3. For example, if A, effect of A is this much, Z is this much, this is exposure. That is third variable. When you combine this and this, we expect this much, we observe this much, then no interaction. Because the expected and observed is the same. Got my point? But if you say that A and Z, you expect this much, but the observed is this much. You are more. So this we call positive interaction. Just now there is no interaction. This is interaction. Or it can be less. You expect this much, but you observe this much. This is negative interaction. It can be antagonistic. When there are two together, they are maybe cancel out something. So it can be synergistic or antagonistic type of kind of statistical interaction. Positive. They call positive or negative interaction, depend. And then, so additive and multiplicative. So if we select relative risk, then we are testing for multiplicative. If we select for risk difference or absolute risk, it can be additive. So today we will learn about multiplicative. Okay. So how the model look like? If you look like this data, quickly, if you look at this data, let's say this is hypothetical data, and then this is the factor A and factor B. If they're together, if there is a factor A, no factor B. If there is factor A, there is a factor B. If both factor A and B is not there, okay? Let's say we have two factors, one together, one separately. So when we have like this, we have put the number here. Then now I'm going to calculate the risk. Risk. How I calculate the risk? When A is not there, B is not there, it's 10 divided by 100. So it's 0.1, right? When A is not there, B is there, is 20, is 0.2. This also 0.2, and this is 40, so it's 0.4, right? So the risk is 0.4, 0.2, 0.2, so this is how we calculate, okay? So now, if it is based on multiplicative and additive, how the model look like? The model look like this. Additive model, you can use this kind of simple formula. If you use this on additive scale, it will be relative risk that you get -1. Okay, when there is a factor A, one factor present, one factor another not present, another factor present, A present, B not present. Okay, so if we calculate from that table, you remember quickly for you to understand. So it is 4, right? Just now it is 4. Relative risk equal to 4. So -1 and then 2 for A is present, B is not there, and B is not there. So it is, so we have 3 on this side. Okay, on additive scale, 3 is on this side, 2 minus 1 is 1, and 2 minus 1 is 1, so we get 2. So it's not equal on additive scale. We have 3 here, and then the result on the right-hand side is 2. Just hypothetical to show it to you what it means. It means that if you use additive scale to assess that data, there will be significant interaction, okay, between the factor A and Z just now that I showed it to you there, okay, based on additive scale. But if you use multiplicative scale, 4 here, and then you have factor A present, B not there, and here B there, A is not there. So on both the sides, it is the same. Means that uniform. This is the same on right side, then there is no interaction on based on multiplicative scale, because here it multiplies. Can you see that? Here is plus. Can you see that? So therefore, this is based on scale. That's why it's statistical. It will have meaning anything or not? We'll see. What is biological interaction? Biological interaction is, that's what I think veterinary and medicine and other things, we are more interested. Because biological interaction, it shows that if you have certain kind of characteristic exposure, then you are likely to, when you have another factor, it can change the risk of the disease. For example, let's say if you take tetracycline. Tetracycline will discolor the teeth. Is it the same for everyone? If you take tetracycline? No. Tetracycline discoloration will occur only if you age less than 10, about 8. So modified. So it means that if tetracycline giving to the young age, there will be an interaction, okay, causing a kind of both together. When they are together, they can have teeth discoloration. But once you are more than 10 years old, this do not happen. So it's not same uniform. All the strata of age group, this is called interaction. If you do the statistical one, you may say it also. Stratum for age group, this one, the effect is different from each stratum. Okay, one example. The second example is that we have a lot of drugs, okay, pharmacogenomics. If you take certain drug, if let's say, during the COVID, we prepared for the influenza outbreak. So we do in TropMed, we do a lot of drug trial. We use oseltamivir, okay, to look at whether if there is a H1N1, H5N1, there is a outbreak, and then how we're going to protect the health personnel. Let's say if I'm going to go to the clinic every day, exposed, and then a lot of cases in the hospital, can I take oseltamivir for 10 weeks? Okay, whether I have side effect or not, I am going to be tolerating with that or not, okay? So what happened is that we observed that in the volunteer, some people who have certain gene, okay, they cannot metabolize oseltamivir because it will not be any use, you see? So that is the interaction between certain genes. If you have characteristic of certain genes, it will not have any effect. But for other people who do not have that gene, no problem. So today, what we are doing is only this particular part, additive and multiplicative scale. So you can see like this, okay? Baseline is this much, Z this much, A this much, but it is beyond, okay? If it is more than that one, then we may look like to tell you about the interaction part. So if you do the regression line, you will see that if there is no interaction, the line likely to be parallel among, okay, with the factor A or factor B, okay? It's not going to be, if it is present, then the line, okay, from exposed from the factor A, no factor A, with factor A, okay, or not, it will be unparalleled. It will be something that is there. So just to show it to you that now this is the part that may be important to you that you have to remember. Okay, the other part is just source, okay? So once you ask the question, is there association between exposure or risk factor X and disease? If there is, okay, if there is, then you usually you will ask, is it due to confounding? Okay, if it is yes, then you go to the part of the confounding. If there is no confounding, then you also ask whether this association is among the subgroup, is it similar or not? Okay, if it is yes, okay, it is similar. Okay, so similar, then no interaction. If not similar, then there is no interaction. But I'm going to reverse this for you. I'm going to ask that first, ask this part first. Okay, you have to ask first that if the effect is the association of the effect similar in magnitude in the subgroup or not. If similar, then you ask for the confounding. Okay, this is the kind of the framework that they have put very much earlier. Okay, still in many textbooks. That's why I would like to tell you that now I would like to make you ask this part first and then this part later. Okay, so that old textbook will have this kind of flow chart, which is now in the modern journal, they are not likely to follow this anymore, but you will see it. Okay, that's why I bring it to you. So therefore, how do we go next? We will use this data again, oral contraceptive. Then we do the stratify analysis now. I do the stratify analysis. Okay, so I have a 3 level of smoking. This is non-smoker. This is 1 to 24 cigarette. This is more than 25 cigarette, 25 and 20 more. And then this is the oral contraceptive. Okay, whether you use oral contraceptive by level of smoking. Now, what happened is that those who smoke, those who are non-smoker is 1.7. Okay, I don't know what happened here. Okay, this is the data. This is the real data from this study. So if they smoke 1 to 24, it becomes something. If you look at the confidence interval, it's not significant. The first one also not significant. But if they smoke a lot, then it is significant because the odds ratio do not include 1. Can you see that? This is random variation. Okay, so the OC, if you take oral contraceptive, the things on the myocardial infarction is not significant. So I'm asking you to look at this one. Can you see this? It says that this 1.7, 0.4, and 2.1 is likely to be not by chance. Something is happening. Stratum specific relative risk. Just one example. This one we call qualitative interaction. There are 2 types also in some textbook, in some journal. in some people who also talk. When you say qualitative interaction and quantitative interaction, quantitative interaction means all the strata have the same direction on the same side of the null value. Means 1.8, 1.2.6, 3.7, but same direction. Same direction. Okay. Risk means all risk. Protective means all protective. Okay. That is quantitative. But qualitative means it will go on different direction. Means that some going harmful, some going protective. This is one example of that. Is we call qualitative interaction. But don't worry about that. Anyway, now I want you to see this one. If this one is significant, if this one is significant, but this is very borderline. That is a problem. If we change here and there, if there is a misclassification, if there is a still the measurement problem and that, this may disappear. And then we see qualitative interaction, statistical interaction also. So this kind of test of homogeneity here is based on multiplicative model. Based on multiplicative model. Okay, you don't have to do that, what I did that for you. So they do it for you, multiplicative model, and then they say that is a significant interaction between smoking and OC. Okay, this just for example for you to see from this data. Okay, that is significant. Let's see next. Now I come back to another data. Okay, similar there. In this one, when they collapse, they are doing by smoking. Here they are doing by age. Okay, and now we can see here that if when we see just now, I already told you, when you look at the whole test of homogeneity, when it is not significant, then you compare crude and adjusted. Okay, so my approach is first look at the crude, stratify, try to stratify, look whether the test of homogeneity is significant or not. Now we will take a look at one. Okay. So from your crude table, you have a crude related list. Now you will stratify. Okay. You stratify table 1. You stratify table 2. Stratify table whatever it is. Stratify. You have related list. 1 specific related list. Here is crude. Here is Pratap. Now the first question you must ask immediately. Second, it is there and between, let's say it is. So data is connecting and third variable. Okay, outcome is already. So if this statement must be is there, is the data anyway is the stratum specific? Are the stratum specific? Is the stratum specific? OR uniform. Are they the same? Are they the same or not the same? Or what they call homogeneity? Are they homogeneous? Are they uniform? Are they the same? Question is yes.
no. If the question is yes, then you default. If you look at adjusted, let's talk about. If no, and that is the evidence of statistical interaction, then mean exposure and the third variable. Okay. So what you do next from here? Report your result. Why? You right. Okay. Don't combine. So you report. This is not a good data, but it's report your data. Why? Report this. This is the effect of the vacuum. Right? Okay. Not combine it. But here, if it is no, then combine and look at. Because if you report all the election, already okay. Now, this is about big data. This is about lung cancer and no, it's exposure to thought. Yeah. And keep that together. The risk. Okay. So we look at the data. And it's minimal smoking. Expose food and the thought. Now don't take it. I just put the number for you. So other men for now. You have metal? Yes. So the question you have to ask, I know already the stratum specific, right? You just saw the stratum specific relative risk, right? Of odds ratio of each stratum. Don't stop there. Should I combine? Should smoking is a confounder or smoking is a effect modifier? Effect modifier means that I think so. We use the word effect modifier. Is smoking a confounder or smoking an effect modifier? So to answer this, we combine. Yes. 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 Why not? That's ready. Right. Please. Now you take your turn.
Now you're expert.
P value more than 0.05.
Yes. Then what happened?
It's not,
What is your
it's
conclusion?
not significant.
Yes. Then
Uh-huh.
what it means? What
It's
it means?
no interaction.
Yes. That is the whole. I don't.
And what? No problem about the one. One, two, three. 1, 2, 3. Is it homogeneous? Is that a startup submission is different or not? That's your eyes. Uniform means whatever you see is uniform. Therefore, there is no significant statistical. There may be some become more than that. Based on multiplicative model, based on this one, based on multiplicative. Always say that. Because additive model will say I got this. That's what they are fighting. So they say that based on multiplicative model, there is no evidence of interaction between OC and between chip building and okay, asbestos exposure and smoking. Okay, and then now we go and then global warming. And this what we call okay. Well, because some people believe the way this is our 1.1. But they do. Why 0.4 by 1.2? Then they smoke and alcohol. And could I just report 1.5, 1.6? Huh? So therefore, I'm just thinking for you that. Now I'm designing data of and my current class can have a but if you do the comparative analysis, now you going to write it. But it's easy. See, not difficult. So I say log hot of of 1 minus t equal to plus the 1 OC. See, I put x1 and 4. Okay, my y here is my both at 0 and 1. I will be on the side 0 and 1. And then my XOC will be on this side. Then I say beta 1, beta 2, beta 2 pH. And that's the confidence minus 1. Then I put beta 3. Okay, beta 3. 1. Then beta 4. Smoke 2. So my smoke have 3 levels. 1 is 0, 1. So 1 will compare with the coefficient beta. This beta 3 will compare level 1 to level 0. This will be level 2. That's why potential will get upgrade. So what happens is that each one will be upgrade of 4 Okay. Let's ask people to take third. So therefore, if you have interaction term, put interaction term, OC and smoking or they have OC multiplied by some that one got and then we have a level OC and by 4. So therefore, to have beta here, beta 5. Gamma. Whatever. And that's that. So this is how the model develops. And then this is something that you see. Not worry about it. You have to practice. And then I generate it. If I put with direction curve, if I put positive part up to beta 4, I don't put the direction curve. I can calculate. And put then I compare these two techniques. From that table, compare that output. Then calculate the density. Each is the more fun to okay. And I'm giving the more and of this output. You don't have time. What actually is that? This is model. It's that stuff. Equally. Without that. So my this is right about that here. And let's say if I say no cigarette and no alcohol. It's not the more. So this one will be equal to the same or correct. So when I say that if you take OC and take OC, okay, and do not smoke, also like or hot or compare or one only take only and not smoke. Not smoke is all the girl will zero. And smoke, yeah. If you do not smoke, smoke will be equal to zero on right. That's one. Cut out. If this OC equals 1, it should be left with beta 1. So if you exponential beta 1, so all these and if the next term, I will put the next term so 1. So if you go and take OC, I don't care about my but I look at this one, it is more of the how can you say that it is not perfect? Even if my believe that directed even if it's not, so what I think, so it's not specific. But I calculate and calculate from the same model to risk of no, because our hypothesis, their hypothesis, not my fault. Maybe there are some other confounders. Maybe that there are some phenomena, but they couldn't see on the study at that time, thinking that take OT. Smoking is the factor of smoking also associated with the so it's a confounder. Because the younger age women are likely to take OT. If you're 45 point, right? So the 20 older so the hormonal not a problem. I'm talking about what the prevent the conception. So what happened is that the younger are likely and also it becomes the confounder. So they adjust in the model. That's why they the most and they adjust for that. But maybe as stop. So what I'm talking about is the opposite kind of the information that that if according to our analysis, if it would be we will modify and if we already accepted by age. Here is age. They put age. This age. The model. After all age in the already, then I see this kind of the effect. What will be the suggestion of the how to find that is I don't know. And then maybe because directed or higher. Directed, they don't listen. Or founding higher. Directed. So the one data. Data. Cannot one. Oh, I have full data. I got the data from everything then further. Why is it something wrong?
A quick question. So that means like before we test statistical interaction, we need to think about the biological interaction first.
what I mean is that now we don't have any idea. We have
Mhm.
only this knowledge on the interaction.
Yeah.
Because the data, you see, I'm asking you, why, let's say, in the past we have one drug we call monoamine oxidase inhibitor for the depression. They have been using a lot. And then one day, we come in the hospital, we saw 3 cases of the people who take this depression and with a very, we call it crisis hypertension. And then they never have it before. They have been taking this drug for a long time. And then suddenly they come with a blood pressure more than 220. Okay. And then suddenly, later on, the research found out at that time. We asked them to stop this drug. But later on, we found out that they have special teeth.
Ah.
And then they take the cheese also. Cheese and the drug together. If you take the tyrosine, which is in the cheese, and then this enzyme, this drug together, they interact. This is biological interaction, which we never know. We know by observing, hey, how come you have been taking for 2 years, and then suddenly you become this one? That day they took cheese. They went to Central Power, and then maybe they bought cheese. They put them, and then suddenly they have it. So this biological interaction. Biological interaction may be gene, and then certain environmental factor. If you have certain kind of characteristic, plus the external stimuli, maybe pollen, maybe this kind of interaction, that will be interesting. But statistical interaction, not explaining all this. They're explaining what? They're explaining multiplicative model, additive model on the scale. Bring the scale. If you're more than the scale or less than the scale. If you don't have multiplicative, you will have additive. So now, what you are seeing in our research, epidemiological research, published everywhere, is about it. But as a public health, you are public health personnel, the medical, the veterinary, what you are interested in, analytical, right? Also, you have to, it's also important. You can tell exploratory etiology way that there is some interaction between 2 variables based on this scale. It may lead into biological interaction later. We don't know. We do not neglect it. That's why I'm still using it just to study the etiology, the phenomenon that we need to explain. Because science progress, research progress. We will not say that not important. Okay, so it's over 30 already. I have so many different but just no. One of the biggest it's so dangerous. And then we do the statistics. Now, okay. And just like it. Is age an effect modifier? Is age an effect modifier? Yes? Very clear. So we can say that the esophageal alcohol being modified by now we're talking about the topic. So that obviously report
age less than 60, age 40. Another one has higher. This is the based on and ultimately on the two would be so therefore I think I have to stop here.
When we practice with our trainee, we always check for multicollinearity or even the VIF, variant inflation factor. But you don't talk about it, or you talk about it.
I am talk. My session is about correct. That is tomorrow, day after tomorrow, tomorrow, day after all statistics. The expert on this one will become. You can ask him any question, Dr. Charanit. You can ask him about multicollinearity, how we check, what is the stepwise, how to put the variable in, how to take it out, how to interpret this, how. But what I'm telling you today, maybe a little bit more statistics side, but I'm just trying to say that what is the pro and con? I'm trying to tell you that not based your thinking on statistical kind of things too much. You have to consider the public health, medical, animal welfare, whether it benefits something in the term of public health, whether it is mortality, whether this one, not based on the statistical value and all that too much. Help to guide you, but it's not going to be the final thing that you make a decision, because there are so other things that you have to consider in that context. But the procedure, how to do it, you are right. You have to say, okay, I know how they do it, but I may do it differently, because that is for my setting. My setting in Nepal is different from my setting in the Philippines, in Thailand. Because of the situation, something like that, I will be needing, because the local resource is limited, okay, for diagnostic. In that situation, should I think, how do I think about the disclassification? Okay, I will try my best to make it non-differential. Okay, so that I can get the data, as well as I will use the existing low resource setting to do the epidemiology. That is more important. Then based on that, we have to have the same size fit or no. But the scientific principle, you have to know that this is what they are talking about. And then if you're going to discuss, we can discuss with them. Okay, I have less information bias. I have selected. I have control for the confounder. I have looked at the interaction.
A quick question. You mentioned to think about the confounder, like we need to base on the literature, right? But in some scenarios, we found it's not have enough literature, especially for the animal health area. There's no enough literature to study the risk factor before in some particular topics. So what's your advice? Like if we don't have the literature and is any other reference we can.
Studying that before that or talking about is studying that. What? Okay. So therefore, your life is much easier nowadays. And more papers are published than those times.
Yeah.
And then the paper that I read is already old.
Mm.
Okay, it's not, you have to go to the latest edition. And then somebody already taken that one.
Okay.
Not in the binding. They
Yeah.
put the binding.
Yeah. So that means like for the if the or trainee plan to do this risk factor study, the first step would be the literature review to check what have been done.
When you 100% find, you have to find a good AI out there. I would say that I look at 15 AIs.
Mm.
And then I look at that which one is suitable for what setting. I
Yep.
think that there are at least 5 AIs are so effective in literature search. They're so effective that they can summarize for you. And then if you could find the paper and then you do not believe that they're going to understand it or not, you put that in the notebook and then they will, and then you chat with them and then ask them to summarize. It will come from the book, the search that you give it to them. They will not go outside. Let's say I put them AP papers. They will summarize with the mind map, with everything. Okay, and then now you dig deep into that. So that's why I say that for the vet, younger like you have to see that how the AI can listen and then you just take the photograph of this one and then feed them to the AI. And then they will analyze everything here, what I spoke. Even deeper if you want.
Yep.
So by the time I get one, I have to read so much. Now you don't have to read it.
Yeah.
They'll read it for you.
Yeah.
Okay. So I think FAO, you think about that mixing AI with the analytical skill of AI, and then make them to be very practical that okay, the vet cannot go to Sigma, Gamma, all those kind of things. Those are for my generation. But for them to say that how are we going to transform epidemiological thinking into the field work? so that the field work improves, and then we can intervene. I think that we, and then we can intervene also, but use technology, use the new kind of the ability for the search and for the thing. Okay?
Yeah, thank you.
I think it's okay already, 4:30. Otherwise, there will be a traffic jam.
Well, thank you very much for.